Welcome to the level 2 or level 4 test 2 workshop. Can everybody hear me okay? Oh yeah, I see you guys are texting me now or chatting. So kind of same as last time. Luckily Zoom didn't crash today, so we're here live. So cool. And I would like to reintroduce Mrs. Burgess. She was my level 4 instructor, and she's working with NIP now, tutoring. So I just wanted to introduce her and let her kind of say a few things about herself. You guys can get to know her. She has quite the reputation.
Let me see, I graduated from this very program in 1982, right out of high school with my ADN, and also graduated from Saving College with my BSN. And taught there full-time for about 8 years. And 2 years ago, I decided to retire to enjoy my husband who had retired and our grandbabies. And there's still a part of me that just loves to teach. So I was like, well, I'll stay adjunct. I'm doing some BSN courses, but I really love the content and I love ADN students. So how am I going to do that? So I talked with the new initiative program and I decided that I'm going to do your workshops and I'm going to do some tutoring part-time, which kind of keeps me involved, and I love that. And level 4 has all the content that just rocks my world because my background is critical care, CCRN, and flight nurse, so it just kind of fits.
Thank you. I also wanted to ask everyone who's coming in, and I'll repost this in the chat for everyone. The chat is to host only, and that's to protect your guys' privacy. Would you all please type your first and last name and then your student ID into the chat? It only goes to me so that I can record attendance. So thank you for that. Ooh, you guys are so good. I'm already getting them all.
Hey, while you're doing that too, because this is a workshop and you guys are muted, if you have a question as I'm going along, please fire it off to Megan. Just fire it in the chat. Megan will pause me and we'll answer it until you understand what's going on. If by the end of the workshop, because we do have a lot of information to get through, something is not clear, then I'll stay around a little bit and we can chat. Okay?
Yeah, thank you, Ms. Burgess.
That's the purpose of this workshop.
And if you guys didn't see the announcement, there's a new packet that's been revised on dysrhythmias, just to update it according to the newest edition of the textbook. And I know a few people have the 11th edition, but most are working out of the 10th. Let me make sure I'm saying those editions right again. Yeah, because I kept calling them the wrong ones.
The red one's the 11th.
So, yeah, we're using the most updated numbers according to the 11th. So
yeah. Paul?
Is that
We're gonna have to
there we go.
There we go.
Yeah. The click of a button. Oh, okay. Let's see. Questions are ready. Will this be posted later for us to review at our own time? Yes, we are recording now, and it will be posted on the NIP Student Commons under Course Content Level 4. Okay, someone let me know they may have to step out for half an hour, so if you miss some, like I said, it'll be recorded. Dandy can't hear me. Can everybody else hear me? Feel free to type in the chat.
Megan, can you still hear me?
Yeah, I can hear you. I unmuted you.
Thank you.
Yeah. Okay, cool. Most people can hear me. And then, yes, we're recording the chat, but that's not going to be made available with the recording because it will contain private student information. but I'm going to be reading out the questions to Mrs. Burgess. All right, so it's 12:30. Again, if you haven't already, let me just let these last few students in. Hi, Marybelle. Good. As these last few are filtering in, if you have not typed in your first and last name and your student ID, would you please do that in the chat now? It's host only chat to protect your privacy, so no one else will be able to see it. Thank you. All right, and I'll let Mrs. Burgess take over.
Hey guys, good to see your beautiful faces. This is so weird because, you know, I'm like incredibly animated and I love feedback. So it's so hard when everybody's muted. But every once in a while, if I'm like, are you guys getting me? Like, if you could just like shake your heads, thumbs up, or go, I have no idea. Whatever it is, just give me some feedback, okay? For those of you that I can see your beautiful faces. So we have a lot of information to cover. I'm going to start by sharing my screen here because I don't have my model since I'm at home. Let me pull this up. Where is my model? Come on. Seriously? It was just here. What? What? Hold on. This is crazy. I just had it, Meg. How did I have it? And now.
Was it under a photo like what you were doing last time?
Yeah, it's under my photos. Okay, so hold on a second here. I think, oh, man.
Usually if you minimize a window when you're trying to share a screen, it won't allow you to share it.
That's
You may have
probably.
to maximize the window.
All right, hold on a second. Let me see if I can. I'm going to exit full screen here for a minute and see if I can pull it back up. Seriously, this is crazy. All right.
It's not a workshop if we don't have at least 1 or 5.
Right? 2 snafus.
We still have people coming in anyway.
So people coming in, good, because this is not working for some reason. This is really annoying. I'm wondering if it's there it is. All right.
Hey.
Do you see it?
No.
Okay, hold on. Hold on. Let me get back to Zoom.
Hi, Sebastian. I just saw that you were like, what's up? With exclamation points. You guys are so funny.
All right, now, share screen.
You guys, level 4, right? Can we just take this moment to fill the silence and
right?
how great you're doing?
Seriously.
Graduate, right? See if I have any questions while we're in this.
I don't understand why it's not sharing. All right, hold on a minute here.
Thank you, Marybelle. And then, yeah, let me actually, to everybody, can everyone cease their chatting? Not that I don't want to hear from you, but I'm just gonna, ooh, yay, it's working. I'm just gonna drop the file that I mentioned because I have a request for the worksheet for the dysrhythmias. So just hold off on the chat and I'm gonna drop that file in here so you guys can get it.
This is the weirdest thing ever. All right, why is it not sharing then? Meg, you still there?
Yeah, I just dropped the file in the chat. It's level 4 dysrhythmia, September 2020.
Mm-hmm.
And I'm still working on revising the level 4 test 2 handouts because that one was from 2016. All the numbers are almost identical though. There we go.
Are we seeing it now?
Yeah,
Hallelujah, praise the Lord. Okay. Man, oh man, oh man. Okay. All right, are we ready?
Yes, and for the last, one more time, if you guys have just entered, please type your first and last name and student ID into the chat. It's private, so your information is protected.
Okay, so I'm going to be going back and forth between sharing my screen with some pictures and then doing some writing up on the whiteboard and then doing a lot of talking. So the first thing we're going to do is we're going to review some anatomy physiology. And let's talk about the pump. The pump is the myocardium. And roughly the pump is about the size of your fist, and it sits behind your sternum in the mediastinum. And if you look at it, you can actually kind of draw a line right here, and you see that the pump is kind of like a V shape. All right, this is the apex down here, and this is the base of the heart up here, upon which all of our great vessels attach. So the myocardium is the most important muscle in the body. And if you've ever heard any of my lectures, you know that the pump is the main P in what we call perfusion. Perfusion is the process of getting oxygenated blood to every cell in the body so that it can work under what we call aerobic metabolism. I'm going to break that down a little later for you. But right now, let's talk about perfusion being the pump, which is the myocardium, pushing the precious prime, which is your blood, precisely through the pipes, all of your arteries that get smaller into arterioles, to the point where we get down to capillaries. And the capillaries are the only vessels that should allow fluid in and out. And that's where diffusion happens at the cellular level. From the capillaries, we come back to venules, and then bigger veins, and eventually back to our big superior inferior vena cava. So while I'm talking about that, let's just trace blood flow, okay? The one handout I'm going to be talking about so you can follow along is called the Level 4 Test 2 Review Cardiovascular System, and it starts with the pericardial cavity. But if you want to, switch over to page 2 and follow me with the blood flow. Now, come on, guys, we're in level 4. So by now, you should be able to adequately and very accurately trace blood through the heart. Okay, so let's say that the blood was down. I hope you guys can see my cursor. The blood was down in my thigh, and it perfused oxygen-rich blood to my thigh so that my thigh could contract. I could run this morning. Once that diffusion of oxygen into the cell happens, then CO2 is going to come back. Most of the oxygen is going to be left. Usually the saturation of venous oxygen is about 75%. Anyway, that venous blood is going to come up from the lower extremity, all right, through the inferior vena cava, and from the upper extremity through the superior vena cava. It's going to come here into the right atrium. Now remember, the heart is divided into two parts, the right and the left, and it's divided by this heavy, this thick septum, okay? And that's keeping right side of the heart separated from the left side. So my deoxygenated blood comes into my right atrium. It goes through my AV valve, that is my tricuspid, and we're going to talk about valves in a minute, into my right ventricle. Then the ventricle contracts, sends it up through the pulmonary valve into the pulmonary artery. Remember, that's the only artery upon which deoxygenated blood goes. It's going to go out into the lungs, and at the alveolar capillary membrane, it's going to get rid of the CO2, pick up more oxygen. Then it's going to come back in through the pulmonary veins, the only veins bringing oxygenated blood to the heart, coming into my left atrium, and it's going to go through the mighty mitral valve into my left ventricle, and then it's going to go through the aortic valve into the huge aorta, the biggest artery of the body. And you notice the first thing that happens is the brain gets fed, and during diastole, the heart itself, the myocardium, gets fed through the coronary arteries that are on the outside of the heart. And then down behind the aorta, right in the retroperitoneal cavity, are our kidneys, and they're going to be getting perfused. And at any one time, they have about 25% of our cardiac output. And so knowing kidney output is going to be vitally, vitally important. Okay, while I'm here, let me just make a mention here of why we have these valves, okay? So here, the AV valves, the tricuspid and the mighty mitral, okay? They keep blood from going backwards. We want blood to keep moving forwards. And if you notice, there is a muscle, all right, right here, that covers around the valve, and these are called chordae tendineae. They're almost like, here's the leaflets of the valve. Here's the papillary muscle. These chordae tendineae almost look like parachutes, and they hold on to the little flaps of the valve, and they pull it up to close it off, okay, to close off. Can you still see me while we're looking at the screen too?
Yep.
Okay, perfect. So all three leaflets.
If you guys can't see her, then you may have to just adjust your view. Sometimes it'll let you like put people in columns or just have speaker view. So play around with the features.
Okay, perfect. So when the papillary muscle contracts, it pulls up the leaflets of the valve and the valve closes. Now we know that things can happen to the valve. The person might have a myocardial infarction and damage that papillary muscle. So instead of 3 leaflets coming up, only 2 come up. Now we have mitral insufficiency or tricuspid insufficiency. Or the same atherosclerotic process that lays down inside of our arteries can lay down in the inside of our valves, narrowing them, okay? And when that happens, we're going to hear extra heart sounds, which we're going to talk about. But I just wanted to point that out right now while we're looking at that. Okay, so I'm going to exit that and come back and see your pretty faces. Okay, there you guys are. Good. All right, so in that pericard, around the heart, okay, it's covered by the pericardium, which is a heavy fibrous connective tissue that encases and anchors that pump the heart in the mediastinum, and it prevents it from moving around and getting jostled too much. Also kind of helps it from getting over distended. It has 2 layers. The serous pericardium is the thinner, more delicate membrane, and it forms a double layer around the heart. You got the visceral layer that is right against the myocardium, and you got the parietal layer. And why is that important? Well, I'm glad that you asked, because between those 2 protective coverings is about 10 to 15 mils of a serous fluid called your pericardial fluid, because we're going lub-dub, 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 60 to 80 times a minute, all day long, and friction could build up. So that serous fluid there, the pericardial fluid, is very important. What else is important is if you get too much fluid there, you can cause pericardial tamponade. You can also get inflammation there. So if you look on page 1 of our handout, I want you to understand that something called pericarditis, anything with an itis, is an inflammation. And you can actually get an inflammation of that protective layer, the pericardium, around the heart. And a lot of times it happens post-MI. You need to know this. I guarantee it will be somewhere on a test. If it's not this test, it'll be on NCLEX or somewhere. There's a thing called Dressler syndrome, okay? And Dressler syndrome, now pericarditis can be caused by trauma. It can be caused by a virus, a bacteria, any microorganism. But in Dressler syndrome, it's specifically post-myocardial infarction. It usually happens 2 to 3 days after somebody's had an MI, okay? Or it can become chronic and happen and last for like 4 to 6 weeks. But what you're going to see, they are going to have chest pain, but you need to know the difference between a Dressler syndrome pericarditis chest pain and an MI. In pericarditis, they're going to go, it hurts right there, and they can almost like point to it, and they might be leaning forward to try to get some relief. Other things that you're going to see is you're going to see a fever, okay, because it's an itis, and they might get pain in their other joints, arthralgia, and your white blood count is going to go up, and your SED rate, your erythrocyte sedimentation, your ESR, that is always going to go up when you have an inflammatory process going on, okay? If you did a 12 lead, you might see diffuse ST segment elevation, okay, which is not a normal finding. And you may hear a pericardial rub. You might be listening to lub-dub, lub-dub, dub, dub, dub. It's not an extra sound like an S3, lub-dubba, 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 and it's not a whoosh-dub, 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 which is a murmur. It's more like the sound of grating or leather rubbing on leather, and you usually hear it over where the inflammation is, okay? So what are they going to do? You're going to get, they're going to be treated with NSAID, non-steroidal anti-inflammatories, aspirin, and probably short-term cortisone use, okay? Do please, it's so important that you compare and contrast things. So compare the clinical presentation of Dressler syndrome pericarditis to somebody who's actually having myocardial infarction and that chest pain that's crushing and up into the jaw and the neck, and they're sweating and yada, yada, yada. Okay, So we went through, if we're going to follow down here on page 1, we already went through the atria and the ventricle and all that good stuff. We went through the valves. Now, at this point in time, you better know where your valves are. Apartment M, okay? So everybody put up your right pointer finger. Come on, let me see it. Okay, good. Now, come down your trachea right till that suprasternal notch, okay? See where I'm pointing there? And then you come down, you feel that manubrium. The manubrium is like the catcher's mitt on the top of your sternum, okay? So if you go right where the manubrium is, where the manubrium meets the sternal body, that's your second rib, okay? I'm gonna try not to show too much of Mrs. B, but that is your second rib. And right under that second rib, right next to your sternum, the second intercostal space, right sternal border. I'm gonna turn this way so you see, right? It's the only valve on the right side. What is that? Aortic valve, okay? Now, cross over your sternum, and the second intercostal space, left sternal border, is your pulmonic, right? The aortic and the pulmonic, also sometimes called the semilunar valves. Now, stay up against the sternum, drop down to your fourth intercostal space, left sternal border, and that is your tricuspid, right? That's the AV valve between the right atrium and the right ventricle. And then right about where your nipple should be, if you weren't 58 years old and had nursed 2 children, right about your 5th or 6th intercostal space, mid-clavicular line is where your point of maximal impulse, or you're going to be hearing the mitral valve. And what we do is we listen at each spot for lub-dub, 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 lub-dub. Then once we get down to the apex, we flip our diaphragm over and we have the bell there. And with the bell, you just lightly place it, because now we're listening for extra sounds like S3, S4, or murmurs, because maybe now we might hear sh-dub, 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 sh-dub. Any kind of a sh sound means turbulent blood flow. If I'm listening, so what I do is I come back over the valves with my bell, and then I ask the person to hold their breath, take a breath, and I listen to both of their carotids. Anytime I hear a whoosh, 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 that means turbulent blood flow. If I hear it over the artery, maybe they have atherosclerosis going on, that's called a bruit. If I hear it over one of my valves, that is called a murmur. Okay, now at this point, you're not going to say, well, that is most definitely a mitral stenotic valve, and I would grade it a 4 out of 6. No, way above your pay grade. You just need to be saying, hey, Miss B, I heard this freaking funky sound at about the 4th intercostal space, left sternal border, during systole. It kind of went whoosh, whoosh, whoosh. Okay, you can describe it. I heard a whooshing sound. I heard a mechanical sound. Okay, and that's what you need to know. And you need to know that it's not normal. Okay, that's the important thing.
Hey, Miss,
so what?
Sorry to interrupt. I have a couple questions.
Oh, go.
Okay, so a really great question. Is chronic considered Dressler's, or is acute and chronic both called Dressler's?
Oh, great question. They are both called Dressler syndrome.
Thank you.
If it happens within 2 to 3 days after an MI, it's acute. And if it prolongs or happens anywhere in that 4 to 6 weeks, it's considered a chronic.
Thank you. And then which handout are you referring to again? That would be the nursing for level 2 cardiovascular review handout. And I'll put that in the chat as well.
Okay.
It's found in the NIP Commons. Anytime we have these workshops, the handouts are found under course content and then your respective level. And any PDF document you see that relates to the test, usually it'll say like test 2. Those are the handouts that we'll be working from, but I'll drop that one in the chat. And then yes, this recording is going to be made available to you guys after the workshop. Yes.
All right.
Okay. Thank you, Ms.
So we know by now, okay, I'm sorry I have to put my backside to you, but we know by now that when the atria contracts, we see the P wave. When the QRS, we see that's ventricular contraction. And then we have the T wave, which is ventricular repolarization. So what happens is, let's just do another one. P, RS, and
Coming
T.
down.
Can you guys see? Okay. So this is ventricular contraction, the QRS into the T. Okay, so that's where we're going to hear S1 or lub. And then from there, where the T wave is, about the middle of the T wave, all the way through the P into the next, before the next QRS, that is diastole. And that is going to be S2 dub. Okay? So this is systole, S1, and we hear lub, and then diastole. So when the AV valves shut between my tricuspid and my mitral, that they're shutting because the ventricles are expelling the blood and the back pressure is making them shut. So that's lub. Then when they open, the semilunars close, and that's dub. So lub systole, dub diastole. The way I remember it is D for diastole, right? D for dub. Lub dub, lub dub, lub dub. Now look how much longer dub is. Lub dub, lub dub, lub dub. Why does diastole have to be 2 to 3 times longer than systole? Because during diastole, your valves are open, blood is rushing into your ventricles, increasing that stretch. Remember Starling's law? The greater the stretch on the myofibrils, the greater the force of contraction. We're going to get more preload in there. We'll define this later to give us more stroke volume, to give us more cardiac output. At the same time that the heart is filling internally, the coronary arteries on the epicardium, the outside of the heart, are being filled. Let me make sure that I tell you that, guys. There are 3, let me see if I can share this and give you another good example. There were 3, maybe I didn't do that. Okay, never mind. All right, never mind that, okay. There are 3 layers to the heart. You have the epicardium, okay, the epicardium is the outside, that's where the coronary arteries are. And then you have a really thick part, that's the myocardium, the meat of the pump, that's the one that does all the contraction. And then the inner layer of the heart, like the inner layer of your mouth, is the endocardium. And that smooth surface is synonymous with all the endothelium of all of your arteries. So it makes sense if somebody is developing atherosclerosis in their arteries, they can be laying down that same process in the endocardium inside the heart, and the valves can get messed up. So sometimes we're not just going to hear lub dub, lub dub. We might hear sh dub, sh dub, dub, because maybe the mitral valve is stenosed, okay, or any of the valves. And so as the blood's rushing through there, we're going to hear turbulent blood flow, okay? How would I know? This is a trick question. It's really not. How would I know if I'm hearing whoosh, dub, whoosh, dub, whoosh, dub, if it's systolic or diastolic? Well, if I can hear it where lub should be, that's usually systolic, but sometimes you're just going to hear whoosh, through the whole thing and you won't know. What you do is you take your stethoscope and you listen while you're feeling for a pulse. And if you're hearing whoosh, 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 when you feel a pulse, that's a systolic murmur, okay? They're not normal. Notice that a whoosh, whoosh is going to be very different than a lub-dubba, lub-dubba. Usually I should just, can you kind of hear that, Megan? That beat I'm making?
Mm-hmm.
Lub dub. Now sometimes you might hear or sounds like I'm drumming, right? Yeah. Notice those extra sounds are not the same as a whoosh, 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 murmur. They're called extra sounds. Now, they occur during diastole, during the filling phase, okay? This, I'm gonna just give you the basic rundown on it. You don't need to know any more than this. However, what happens is early in diastole, the AV valves are open and blood is filling up my atria. Would you agree? At the very end of diastole, that SA node fires and I get atrial contraction. That's my P wave. That pushes another 30% blood volume down into my ventricles right before.
Hey, real quick, since you're on that real quick, I have a question, really good one. All these are great. So is systole QRS?
Yes, yes, yes. Okay, so systole is QRS. And then from about the middle of the T all the way through the P to the next QRS is diastole.
And there's
Brilliant.
a slight difference between depolarization in systole versus repolarization in diastole. The depolarization, repolarization is like the nerve impulse almost. I always think of cardiac muscle cells as like if a nerve and a muscle cell had a baby. And so the depolarization, repolarization is like the electrical signal saying, hey, contract, hey, contract. And then the contraction is actually shortening of the muscle fiber, so it's mechanical, which is, there's the slight difference is significant because there's something called pulsus electrical activity where you can be depolarizing or repolarizing and you can be sending out the electrical signal, but you actually don't have a contraction. Where you
That's
wouldn't,
a really good
you would
point.
see, like the first patient that I had, unfortunately, who passed away, he had pulseless electrical activity. He looked like he was in sinus bradycardia, but his heart was not contracting.
That brings up a really brilliant point, Meg, that we don't treat rhythms, we treat patients. Anytime a rhythm changes, we go and we put hands on our patient. Okay, we're going to talk about that later. When we put a pacer on a patient, I might see a pacer spike and I might see a QRS, and so I know I'm getting some, like she said, depolarization, the electrical. I better go feel for a mechanical pulse. Do I feel the contraction? Do I feel the result? So they are kind of synonymous, but they're definitely different. But when you hear depolarization, think contraction, repolarization, rest. And take it back to fluid and electrolytes. What's causing depolarization? Remember, at the cellular level, what's causing depolarization is you have potassium inside the cell, and you have sodium, more sodium on the outside of the cell, okay? And that's giving us kind of a process of electrical negativity. So there's nothing happening. All of a sudden, the sodium gates open, sodium rushes in. But because it's a positive cation, there has to be balance, so potassium will leave. That gives me, woo, a big bolt of electricity, starting my SA node, going down to my AV node. Now at this time—
Sorry, I have two more questions.
Yeah.
One student was wondering if you can bring the whiteboard forward a little because the glare is making it hard to see that.
Okay.
It's like tilted so that the light that's on, I think, is glaring. Maybe like
Gotcha.
scoot it to the one side.
Is that better?
Scoot over a little bit. It's better when you do it like that, I think. Yeah.
All right, I'll hold it up when I do that, okay?
Yeah, and then also, someone had asked, is atrial, I thought atrial depolarization happens in the P wave, which is atrial contraction, and in the QRS wave, we have ventricle depolarization and atrial repolarization. That
Correct.
would essentially be covered up by the QRS complex because
Correct.
it's smaller.
We're not going to see atrial repolarization because of the big QRS. Correct. But what I'm saying is depolarization, think contraction, repolarization, resting. And here's what I'm showing you. Here's depolarization. Sodium rushes in, potassium comes out. Eventually, through the slow calcium channels, calcium comes in. Now that shoots up a big action potential. But then eventually ATP is spent because the nucleus doesn't like salt. It wants that sweet potassium banana to come back in. It's going to be the sodium potassium pump. And that is occurring, the sodium potassium pump, during the T wave. The ventricle repolarizes during the T wave, and technically the atrial repolarizes during the QRS. Okay? So the P is atrial contraction, atrial depolarization. The QRS is ventricular depolarization, ventricular contraction, and at the same time you won't see it, but the atria would be repolarizing. And then your T wave is ventricular repolarization. Okay, it's resting. The sodium potassium pump is kicking in. Now what I want to show you, really important, right where the S and the T come together is called our J point. And our J point is vitally important. It's showing like almost the beginning of repolarization. And that's when blood is going to be coming into the heart. It's also going to be filling my coronary arteries. So if I have coronary artery disease and I'm having ischemia, injury, or infarct, I'm going to see a change in that J point. I might see depression or I might see elevation. We're going to talk about that later, but that's where I want you to look at it, okay? What I realized is I don't have something to wipe my board, so 20 seconds, hold on.
Is
I
that
got
how
to
you
go
end up with a STEMI? Is that how it shows that?
Say that again.
At that point, is that why you see ST elevation? That's where your tombstone?
She was talking about the J point, you mean, like where it
Right.
reaches the isoelectric line?
And then comes back up.
That would be where you would, if it didn't touch the isoelectric line and it stayed up, that would be a STEMI, so an ST elevation MI. And if
Okay.
it's like, that would indicate infarction. And then if you have it as a depression, that's ischemia.
We're going to talk about that in a little bit. We're going to stay in line with our
Thank you.
handout. I promise we'll go over it. Good questions, you guys. Okay,
I know you're
turn the page.
I love
Now,
it.
now the next thing I want to talk to you about are extra sounds, and this is on top of page 2, and that's where we might hear S3 and S4. So during diastole, right, blood is passively filling into the ventricles. As long as they're not damaged, the myofibrils will stretch, and we won't hear an extra sound. But if we hear it early, okay, so here is, we got S1, I'm going to put it up here, S1, S2, S1, S2. So systole, diastole, systole, diastole. Okay, so we hear lub, dub, lub, dub. Now, both of these ones I'm talking to you about are going to occur during diastole, during this filling stage of the heart. The first one is going to come early, okay? So we have S1 happening here, S2 happening here. Early during diastole, right about here, we might hear an S sound called S3. Lub-dubba, 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 lub-dubba. And then eventually at the end of diastole, when the SA node fires and the atria depolarize, that's pushing another 30% blood volume down into these ventricles. If they're already overfull or they are stiff, they're going to make another sound right around where you would see the P wave, and that would be talub-dub, talub-dub, talub-dub. Some people say S4 sounds like Tennessee, 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 and S3 sounds like Kentucky, Kentucky, Kentucky. Some people say stiff-wall. Whatever you want to say, it doesn't really matter. It's just an extra sound. And then on occasion, those two sounds will come together and sound like this. Sounds like somebody swallowed a horse. That is called a summation gallop when you have an S3 and an S4. All I want you to know at this level, if you're getting a patient in your scenario and they have an S3 or an S4, you have a weakened pump. You have a stiff, non-compliant ventricle. Okay, so maybe they're having an MI, maybe they're already going into CHF. That's all you need to know about that. Okay, so now we're coming down. We already did the blood flow. Let's retrace the electrical activity. You already know, I talked to you about what causes the electrical activity, and those are your wonderful charged particles, your electrolytes, specifically sodium, potassium, calcium. And if you think about when I taught fluid and electrolytes, you have to have potassium to start that electrical impulse, right? And then calcium helps cause the contraction. And magnesium works at the myoneuronal junction to keep it mellow, like not too much, but we have to have enough. So all of our electrolytes are vitally important in the normal electrical action within our heart, okay? There's a principle called automaticity, which means that almost any cell in the heart can generate a beat. And the one that is going the fastest is gonna lead the parade. Okay, so we were created to work this way. So the first thing is the SA node, okay, the SA node up here, and that's in the back of the right atrium. When it fires, it goes down your internodal pathways. It normally beats between 60 and 100 beats a minute, okay? And it's important because at the end of diastole, we want to get all the blood out of the atria down into our ventricles, okay? One right here, we have the AV node, the atrioventricular node. It will hold the impulse for a fraction, I think a millionth of a second, so that the right and the left impulse will go down the bundle of His and then down the right and the left bundles and out the Purkinje fibers. So when the SA node fires, we see the P wave. That means atrial depolarization, and the atria will contract. The time that it takes the atria, the SA node to fire and get to the AV node should be less than 0.20 seconds. And later on, we're going to talk about a first-degree AV block. What can happen is from medication or damage to the myocardium. Let's say the person had an MI, and the SA node fires and the impulse starts coming down, but it can't get below that block. It has to go over here and come that way. Might take it a little bit longer. If your PR is longer than 0.20, we're going to say there's an first degree AV block, okay? So then once the impulse gets to the AV node, by the way, the AV node has an intrinsic rate of about 40 to 60. So if the SA node poops out, the AV node can take over, all right? And the ventricles themselves have an intrinsic rate of about 20 to 30. Not a whole lot there. It's not going to keep you alive long. Once the impulse goes from the SA node, gets to the AV node, and it goes down the bundle of His, down the right and left bundles, not the Purkinje fibers, we're going to see the Q, that first negative deflection, the R, the first positive deflection after the Q, and then the S, that's the negative deflection after the R. The QRS, which is going to be, should be less than, does the book say 0.10 now or 0.12? Should be less than 3 little boxes. Do you know, Meg, the normal QRS?
It's less than 0.12, so that would be less than 3 small boxes.
So it's still 0.12 because I didn't know if they, guys, with this new 11th edition, they may have changed some things. So I just want to be fair. So the QRS should not be greater than 3 small boxes or 0.12. Then,
I'm sorry to interrupt. Would you be able to tilt the board forward just a little bit more because we're still getting there? That's perfect.
okay.
Is
Okay,
that
sorry,
possible?
sorry guys.
Yes,
So
sir.
then the P is the atrial contraction. The QRS is ventricular contraction, and during that time, the atria is repolarizing. Then the T wave is when the sodium-potassium pump is going on in the ventricles, and the cells are repolarizing, okay, and that is rest. So now you know what the P, QRS, and the T is. By the way, you should know the normal QT interval. The time that it takes the ventricle to depolarize and repolarize should be less than 0.40 seconds. Okay, 2 big boxes. That's all good to know. And don't forget about this little point here called the J point, which we will be looking at when we look at our EKGs to tell us if that person is having ischemia, injury, or infarct. Okay, next thing. Okay, let's go ahead and go to the next slide, or the next piece of paper, sorry. All right, now we're going to be talking about cardiac output and stroke volume and preload and all that yummy stuff. Okay, let me wipe out my little heart here and redo it. By the way, I have this here because I wanted to show you that the ventricle, the left ventricle, is at least 30 to 50% thicker than the right one, and that is because the left ventricle, why are you doing this? The left ventricle has to push blood from the tip of my head to the tip of my toes, and the right ventricle just has to go right next door, poof, to the spongy lungs. So
Hey,
the right ventricle is
sorry to
not near as thick as the left.
I guess the glare is kind of like impairing it all. So would you be able to turn the dining room light down? Someone had that?
Okay, I'm going to turn it off and let's see how that happens. Now you can't see anything, can you?
Oh no, it actually looks better, I think.
Does it really?
Yeah, it does.
All right, we're in the dark. It's all good.
Thank you. That was
okay. That better? All right, good. I just can't read what I'm seeing here, but we'll be all right.
Oh, you can't read it.
No, I'm kidding. I can do it. Okay.
No, maybe if you open your blinds a little bit more in the back, it'll create light for you, but take the glare
Here,
off.
let me open this door.
Thank you guys for your patience.
I don't know. Of
There's
course,
always
it's all rainy outside, and I'm in the darkest room of my house. Okay. It's okay. It'll work.
Or even if you if you slid the board over to my right, like out of the screen that way, because there's not a glare on the far right. I guess your far left side of the board.
Okay, hold on one second. I'm gonna try something else.
There we go.
Is that better?
Is it dimmer?
No, it's in the foyer. Okay,
Oh,
that's
okay.
better.
Yeah.
Okay, and then I will lean it forward. Okay. Oh, all this technical stuff. Sorry, guys.
Yeah.
So we already talked about the electrical activity. Let me just catch my thoughts here. So now we're going to talk about some pressures. Okay, we're going to talk about some some terms that you really need to know. Just like your fist, your heart is about the size of your fist. We already talked about it. It's in the mediastinum. You have 5 fingers unless you've had an industrial accident. So your normal cardiac output should be between 4 and 8 liters a minute. Roughly about 5 is the mean. So cardiac output is about 4 to 8 liters a minute. Now let's define cardiac output. Cardiac output is the amount of blood ejected by the heart each minute. So we need to do some other determinants to figure that out. Okay, so cardiac output, and you probably will have maybe a couple questions about this, is your heart rate times your stroke volume equals your cardiac output. Well, you can take the heart rate by just taking a pulse, okay? If they're going to give you a question for you to calculate what the cardiac output is, they would have to tell you the stroke volume. But I'm going to tell you that you can estimate somebody's stroke volume just so you understand the principle. The stroke volume is the amount of blood ejected by the ventricle each heartbeat. So if you're thinking that my cheeks are the myocardium, then I'm going, every time the ventricle contracts, the amount of blood ejected is called the stroke volume. The volume that the heart strokes out each heartbeat is the stroke volume. Now, it very closely relates to your pulse pressure, okay? So, what is the pulse pressure? Remember in level 1, the difference between your systolic and your diastolic. So if your blood pressure is like 120/60, roughly, you have a stroke volume of around 60. If your blood pressure starts dropping to like 100/80, look what's happening. Your pulse pressure is narrowing, which means your stroke volume is narrowing. What would the heart have to do to keep the cardiac output stable if the stroke volume, or the amount of blood ejected each heartbeat, is narrowing? Well, look at your equation. The heart rate would have to go up. The heart rate would have to go up, okay? If the stroke volume goes down, the heart rate would have to go up. And conversely, let's say somebody goes into a bradycardia. If the heart rate goes down, the stroke volume would have to go up in order to keep the cardiac output stable. I know in the past we've had questions about if the stroke volume and the heart rate stay the same, but the cardiac output has gone down, what is going on? That means the myocardium itself is weakening. Now we have decreased contractile force, okay? So I would know those terms, cardiac output, stroke volume, and heart rate, okay? We already know that blood pressure is cardiac output times resistance, the amount of blood pumped each minute through how narrow or how open your pipes are. Okay, now, the normal cardiac output is 4 to 8 liters a minute, but what is more telling, and I think that's on the next page. You know what, guys? I'm not going to go through the regulators of blood pressure. You guys can read that on your own. You know, we have baroreceptors that are very sensitive to stretch and pressure, and we have chemoreceptors that are very sensitive to chemicals like hydrogen and CO2. So you can read through that on your own. Just know that the myocardium is under the control of the autonomic nervous system, meaning the sympathetic nervous system, which is going to make it through epi and norepi beat faster and beat stronger, and the parasympathetic under the control of acetylcholine, which is going to make it slow down and beat less forcefully. Okay, so we're going to talk about different medications that we're going to give when the heart does different things, and most of the time it's to affect the heart rate or the strength of the contraction. Let me give you 2 definitions for a second while I'm thinking about it in case I forget later. You may see the term chronotropic and inotropic. Okay, chronotropic means heart rate. Chronotropic, if I ask you to put something in chronological order, it's in numerical value. So if I say that epinephrine has a positive chronotropic effect on the heart, what I'm saying is it increases the heart rate. And conversely, I would say a beta blocker, low pressor, has a negative chronotropic effect on the heart. okay? So chronotropic has to do with heart rate. Where inotropic, ions like calcium and sodium, potassium, which I already showed you over here, they have to do with contractile force, okay? So most of the time, if it's a negative chronotropic, slowing the heart rate down, it's also a negative inotropic. And if it's a positive chronotropic, like epi, increasing the heart rate, is also a positive inotropic, increasing the force of contraction. Can anybody think of a medication, let's see if they come up with it in the box here, that is a negative chronotropic, but a positive inotropic?
Yep, we got it. Digoxin.
Yay! Did we say digoxin, right?
Yeah, so
Digoxin slows the heart rate, negative chronotropic, but it's a positive inotropic. Okay, very good, very good.
The way I remember that is I read somewhere that digoxin, you know, the generic name is digitalis, and it's derived from a plant in the Amazon, and that tribes in the Amazon, when they would go hunting or use poison darts, would use the digitalis on the end of their poison darts because it would slow the heart rate so low that the animal would die.
Yes,
So
and that's why you said we use such a small amount.
Yes, exactly. Why they dose it in like micrograms, basically.
Right, brilliant. And that's why we have to be careful about dig toxicity. And we always have to know what our potassium is before we give it. And we need to know what our calcium, all of our electrolytes, we want to make sure they're in balance and that we don't have prolonged QTs and stuff, because we can actually make somebody dig toxic, and that's not good. That can kill them.
Yeah, and there
Okay,
are some drugs, real quick, that if you're giving them and it prolongs the QT interval or affects the EKG in some way, most floors, at least at Baycare, their patients are all on tele. You have to be on the floor. I mean, on the phone with tele while you're giving the medication, especially if it's, you know, an IV push.
IV push.
Like, I think one of them is Haldol, if you give that IV.
Because it can prolong the QT
interval, so you have to know about your drugs you're giving.
Okay, so let's go to page 4 there. And I just want to see, I thought we had RAS somewhere else, but we don't. So let's go there. Okay, if we talk about on page 4, there are some things that are going to affect our heart. Now, if you notice in this drawing, remember, I am not an artist, but the heart is going to initially feed itself during diastole through the coronary arteries. The left, obviously, feeds the left, and that's far more important than the right, because the left, again, does 80% of the work. You have the left coronary artery, that you have like a left main that comes down. We call that the widowmaker. If you end up occluding your left main, you're usually dead. Then the left anterior descending, and then we have the right coronary artery, and then we have the circumflex. And they're not gonna expect you to know which artery feeds what. The reason I'm telling you that is because we can determine, if we know which artery is blocked, what area of the myocardium is probably going to be infarcted. What I want to talk to you about right now is a thing I like to call the razzmatazz. The heart feeds itself, then it feeds the brain, and then it comes down the aorta, and these little things that looks like dog ears are actually the kidneys. And that is your renal system. And I tell students all the time, the kidneys are the eyes into the soul of the cardiovascular system. They will tell you what your perfusion is doing. So they always have about 25% of the cardiac output at any one time, and they're filtering it through all the little nephrons, those millions of Mr. Coffee filters, getting rid of the bad stuff, bringing back in water if we need, keeping the proteins, all that good stuff. Kidneys are so dang important, and they're so cute. So you really need to get up and close and personal, know what people's kidney function is. So what happens is, if they do not get perfused, okay, and we know they're being perfused if they're able to make adequate urine. They should put out urine at 30 mils an hour, or more specifically, 0.5 mils per kilogram per minute. If we start seeing a decrease in urine output, which I call technically piss poor perfusion, it won't be in the book, that's my term. If you don't have enough perfusion to make piss, that's called piss poor perfusion, okay? And so I'm gonna say, well, something's not good here. Either the pump's not working, either there's not enough prime, maybe not enough water in the river, or not enough hemoglobin trains in the red blood cell train, or it could be the pipes. Maybe I have hypertension, too tight, or atherosclerosis, but something is causing me not to get blood flow to my kidneys to make urine. Okay, when that happens, the kidneys don't know why it happens. They do this wonderful thing called razzmatazz. R-A-A-S.
Can I share my screen and I'll kind of write what you're writing with so that it's
Yes.
a little clearer? Okay.
Can you not see now?
It's just like really blurry. So I can just kind of like share the iPad screen. It might be.
Well, you know what? I whiteboard it. Why don't I whiteboard it? Want me to do that?
Yeah, sounds
All right,
good.
hold on. Let me give me my whiteboard. Whiteboard, share. Okay, because if I don't do it while I'm talking, I'm going to be messed up here.
Yeah.
So, and then I want to draw. Okay, and I want to have a thicker line. So, R, oh, not that.
I think it was the highlighter one you liked last time.
That one. R-A-A-S. You guys see that, right? So the first thing that happens is the kidneys secrete renin, which is a hormone. Okay. Now, again, the kidneys don't know why they're not being perfused. They just aren't. So the body is under attack. We have limited perfusion. So we want to get the blood to the heart, brain, and lungs. We don't need it in the duodenum. We don't need it in the sex organs. So it is going to make angiotensin 1. I got fat fingers, guys, sorry. From the liver, turn into angiotensin 2 in the lungs, okay? Now, angiotensin 1, if you guys can still see me, if this is an artery, angiotensin 1 can't do much, but angiotensin 2 can put a major clamp down, causing potent vasoconstriction. Why do I want that? Because I want to shunt the blood north to my brain, my heart, and my lungs, okay? Now think about this. When somebody has hypertension, because their pipes are too clamped down, what do? We give them an ACE inhibitor right here. It prevents angiotensin 1 from becoming angiotensin 2. And angiotensin ACE inhibitors often cause a very horrible cough, especially in our African American population. A lot of times people can't tolerate it because it's irritating cough, because it's made from 1 to 2 in the lungs. We've heard a lot about our ACE2 receptors with this flippin' COVID thing, right? So angiotensin 1 becomes angiotensin 2. We have a potent clamp down, sending blood to the essential parts of our body. Now, the next thing that happens is there's little dingleberries that sit on your renals, sit on your kidneys. They add to your renals. They're called your adrenal glands. And they secrete aldosterone. Anything O-N-E is a hormone. So aldosterone, okay, now remember, your kidneys don't know why you're not perfusing them. Aldosterone, if you don't remember what it does, it's right in the word, S-A-L-T. It makes us reabsorb sodium. And sodium, water follows sodium. Now, if the reason I got piss poor perfusion is I have low river water, I'm hypovolemic, then bringing aldosterone, bringing more water back is great. But if the reason I have piss poor perfusion is because I've had an MI, and now my ejection fraction is dropped and my cardiac output is dropped, and I keep bringing more water back into my pipes, that's going to be counterproductive. So think about CHF. We give them diuretics. We might even give them aldosterone blocking ARBs, angiotensin receptor blockers, or we'll give them the things that block aldosterone.
Miss B, real quick, I had a question from a student.
Yes.
Is angiotensin 1 free floating, or is it produced when the kidneys tell it to? I think maybe that's referring to angiotensinogen, which is the precursor molecule produced by the liver, because I know that's like the precursor molecule that's sort of free floating. And then the angiotensin, do you want to take over from there? He also said produced by the liver when the kidneys tell it to.
Right. You answered it, I think.
Okay.
I think that's it. Okay, the S is for sympathetic nervous system, because we have epi and we have norepi. Now, I'm going to erase my screen here, and I want you to think this. We have one heart, and we have 2 lungs, and here's the trachea and the bronchi, okay? So beta 1 receptors are on the heart, 1, 1, 1. And beta 2 receptors are on the bronchi. So if I am under attack, Okay, if I am in a stress situation, I want my heart to beat faster and beat stronger, and I want my bronchi to dilate to get me more oxygen. By the way, my pupils will dilate, and I will get an increase of glucose release. Cortisol will increase to try to give me more sugar so that I can fight whatever this fight is, okay? Now, when somebody has an MI, okay, their myocardial muscle is damaged. And what do we do when we damage a muscle? When the football player, a hockey player damages their hamstring, they go on rest. They don't want them to use it. Well, unfortunately, we have to keep our heart pumping. So what we do is we give beta blockers that try to prevent when epi comes circulating around, it won't have the positive chronotropic, positive inotropic effect. But beta blockers, unless they're specific selective, can also block our beta 2 and cause bronchoconstriction. That's why when we give a beta blocker, we're always listening to our lung sounds. We don't want to hear wheezing. We want to make sure the patient's breathing okay. One more thing I want you to think about. The faster and harder my heart beats, the more oxygen it requires. That's called your MVO2. MVO2, your myocardial oxygen consumption. So after somebody's having an MI, we're going to talk about this, we're going to give them medications to slow down the heartbeat and make it not beat quite as strongly, okay? Any questions?
Uh,
Go ahead.
yes, I do. I was just gonna talk about cause I was doing practice questions and things like that, and then I came across with a question that they're asking like what kind of medication that they're gonna give after MI, and then I forgot what the other choice is, but like they will have like DIG, beta blocker, epi, and something else, but came across the answer is beta blocker.
Right.
Is that because of the beta blocker is like for heart rate and the blood pressure, but
That's right.
the other DIG is only for the heart rate and something is only for the blood pressure, but you want that medication as for both.
Right, and you brilliantly said we want to block the beta receptors so that I can rest my heart as much as I can. Because it's been damaged, so I want it to rest, but I can't stop it completely or the patient will die. Okay, that's great.
Okay.
On page 5, great question, guys. On page 5, I wanted to define preload and afterload. This is very important. What you need to start thinking of in terms is when I'm giving this medication, what is it doing to my preload? What is it doing to my afterload? Okay? When I say afterload, I want you to change it up to after resistance. Okay, so let's think about this. Now, before in my illustration, I used my mouth. I'm the myocardium. So I fill up. So I have to get enough fluid in there before I can stroke it out. Does that make sense? So the amount of fluid in the ventricle, the amount of fluid, that volume, which is causing a pressure in the ventricle prior to contraction is called preload. Yeah? So here's the ventricle. The more blood I can get into it, the greater the stretch. And the greater the stretch, Frank Starling's law says, the greater the force of contraction. Much like if I am going to shoot a rubber band, the further I pull it back, the further it's going to shoot to a point. Then I may overstretch it. And we can do that with the myocardial fibers as well. But we want to have adequate preload, adequate stretch, adequate volume and pressure in the ventricle so that we can have adequate stroke volume, okay? So I have to have enough preload to give me enough stroke volume to give me enough cardiac output. Think about how can I increase preload? Well, I can give them more fluid. I can give them more isotonic saline, isotonic fluids to fill up my river. That would give me more preload. Does that make sense? Okay. Or a vasoconstrictor. If I gave a vasoconstrictor, that would push more blood into the atrium, into the ventricle, and increase my preload. How would I decrease my preload? Take volume away, right? So give a diuretic, Lasix, Bumex. Also, if I take my arteries from being tight and I open them up, I push blood away from the heart. So vasodilating, antihypertensive medication meds will oftentimes decrease your preload. Okay? Does that make sense? Good?
I do have a question from a student. To block the RAS system, why do we prefer ARBs over ACE inhibitors? They both prevent the effects of RAS, but is there a specific situation where we'd use one versus the other? And the
Brilliant.
situation I know of is, you know, usually people will start off on ACE inhibitors, but if they have a reaction like angioedema from the ACE circulating, then they'll—
Or that cough, that annoying cough. A lot of people can't tolerate it.
Yeah.
So that's brilliant. And angioedema, if you've ever seen it, it is not funny. It's kind of funny, but it's not. I mean, these people's lips get like this as the way out.
That Will Smith
Life-threatening.
pitch where he gets the allergic reaction and he has like the big puffy face. That's what that looks like.
Yeah, not
And
good.
if the medication is given to vasodilate, wouldn't that affect the heart the same way and allow it to fill more, increasing preload? The thing I would want to say about that is it causes venous pooling away from the heart. So it's allowing blood to spend more time in the peripheral tissues, as opposed to like the
Shunting it back.
system where you're trying to shunt it back to the heart.
Think about this. If I have water in a hose and I squeeze it, it's going to push it back to my heart. If I open up and I don't squeeze and I increase the size, that will prevent fluid from getting back to my right atrium and my right ventricle and then my left atrium and my left ventricle.
It's a little
Great questions.
counterintuitive. Yeah, you guys are great.
I love critical thinking. Okay, now this next term throws students and it shouldn't. Okay, so here's my ventricle and I am getting ready to stroke out my stroke volume. And let's say that this is my artery. Okay, it's really tight, like 140/90. And I'm having to go and push really, really hard to get the blood through that. Let me get my other thing. Hold on. Stay tuned. As opposed to a great big open artery, right? This is my smoothie straw. Like you got a pressure of 120/60. I can go all day long. No resistance. I'm not working hard. Okay, because with hypertension, that increased resistance against the ventricle is making my ventricle work so much harder, and the harder it works, the more oxygen it requires. So if I go from vasoconstriction to vasodilation, now my ventricle doesn't have to work as hard. So afterload, let's call it after resistance, is the resistance the ventricle has to overcome in order to eject the stroke volume. It's the resistance or pressure the ventricle has to overcome to eject the stroke volume. It has everything to do with systemic vascular resistance, which has a lot to do with your blood pressure. So if my blood pressure goes high, I have like a piccolo working really hard. Whereas if I'm vasodilated, I have a normal pressure, more like a trumpet, much easier to push that blood out. So think about this. If somebody's had an MI, I want to decrease the force of contraction. I want to decrease how hard my heart is working. So I'm going to decrease the afterload. I guarantee you're going to get questions as to how does this med affect afterload? How does this med affect preload or what have you? So if you're looking at medications to decrease afterload, which 90% of the time we're trying to decrease it, I want vasodilators, ACE inhibitors, angiotensin receptor blockers, beta blockers, diuretics. If I take volume out of there, that will also decrease my afterload. Conversely, if somebody goes into shock and we want to try to vasoconstrict, what will increase afterload? Anything that causes vasoconstriction. Epinephrine, norepinephrine, dopamine, Doputrex. Okay, does that make sense?
Yeah,
Now,
I have a question from a student. Did she say preload is before resistance? Just want to remember the sayings correctly.
correct. Preload is the pressure inside the ventricle prior to contraction. So Preload is here in the ventricle, okay? Afterload is really at the aortic valve and out, all right? That's why I like you guys to say after resistance. After resistance, afterload is the same thing as systemic vascular resistance, which really has everything to do with how wide or how constricted is my aorta and the rest of my systemic vascular structures.
Yeah, and I think a lot of students get confused between what afterload is and what stroke volume is.
Yeah,
because you
two different things.
Yeah, because you assume that because preload is volume, you assume that afterload is what comes out. That's actually the stroke volume. Afterload is like the resistance, like Miss B was saying. I always use the metaphor of like, it's as if I'm trying to open up a door and there's this big burly guy like pushing it closed. My afterload increases. And that has
That's right.
so much to do with both pulmonary vascular resistance for the right ventricle and systemic vascular resistance for the left. And that's the pressure that it requires to overcome to get out to the tissues, whether they're in the lungs or the body.
And that leads in to what we're getting ready to talk about. We can actually measure these pressures, okay? So back when Florence Nightingale and I were working in the ICU together, we had a thing called the CVP, the central venous pressure. She's laughing. I love it, Victoria. You don't believe it, do you? Good. Okay. So we would take a catheter and we would put it in like through the jugular or the subclavian, and it would sit right outside the right atrium. Okay. And it would read the pressure. Okay. So a normal CVP, if you look on page 5, is 2 to 8 millimeters of mercury. It's not high pressure. Okay. So think about this. When the heart fails, 9 out of 10 times, the left ventricle fails first, and the blood is going to back up into my right atrium, and then it's going to back up into my pulmonary veins, and then it's going to back up into my lungs. Remember, oxygen diffusion happens at the alveolar capillary membranes. Now, all of a sudden, this pressure, normally my spongy lungs are nice and open, they start filling up with fluid. So now my pulmonary artery is got pressure, and it backs up into my right ventricle, and eventually it backs up into my right atrium. And then and only then does it back up into my superior vena cava and up my jugular veins. If I'm waiting for my CVP to go up, that patient is already in failure, okay? I should have already picked up the fluid in their lungs. They probably have crackles, they might have shortness of breath, tachypnea, their SATs might be down. So what they did, Dr. Swan and Dr. Gans came up with what we call a pulmonary artery catheter. Okay, so remember, oh God, I hate when markers don't work. All right, pulmonary artery catheter. Here's the septum, there's the tricuspid, there's the mitral. Okay, so what I want to show you, because I'm not an artist, is, again, blood comes in through the superior vena cava and the inferior. It goes into the right atrium, into the right ventricle. Then it's going to go out the pulmonary artery and then it goes into the lungs. Then once it's oxygenated, it goes back the pulmonary veins into the left atrium, into the left ventricle, and out the aortic valve into the aorta. Now, what a PA catheter does is it comes in through the right atrium and the right ventricle, and then it goes out into the pulmonary artery. And if you think about it, and we don't do this anymore, but there's a balloon on it that would wedge. And if you think of the end of the catheter as kind of like a camera that can read pressure, it can read the pressure from the pulmonary veins all the way through the right atrium and into the ventricle. So a pulmonary artery catheter can actually tell me what my preload is in my left ventricle. If you look at it, it says the CVP should be 2 to 8 millimeters of mercury. Okay, and then it says the pulmonary artery wedge pressure, PAWP. When we blow up the balloon, which by the way, we don't do that anymore, that pressure should be 6 to 12, okay? And what we do now is when you have a PA catheter, it's going to be giving you a waveform kind of like this. And it's going to be giving you a systolic and a diastolic number. So what we've realized is if we watch the diastolic number of that pulmonary artery pressure, which you can see right there, pulmonary artery diastolic pressure, it's between 4 and 12. What I would know is you don't want that wedge pressure or that pulmonary artery pressure to go any higher than 12 millimeters of mercury. If in your scenario it is saying that your patient's pulmonary artery pressures are up in the 15s, that is high pressure. There's too much volume and the ventricle is failing. So that means blood's going to back up into the left atria. It's going to go back through your pulmonary veins and end up in your lungs. Okay? When the heart fails, when the left ventricle fails, backs up from the left ventricle, left atria, out the pulmonary veins into my lungs, left lung. So think about, that's the worst kind of heart failure. All your left-sided symptoms are having to do with respiratory. Crackles, wheezes, shortness of breath, tachypnea, decreased sats, dry, non-productive cough, or even a pink frothy cough. Whereas when the right side of the heart fails, it backs up into the right atrium, then it goes up your jugular veins. You might see jugular venous distension, periorbital edema. So I think of right failure, rest of body. So jugular venous distension, periorbital edema, dependent edema, a positive hepatojugular reflex where if I push over the right upper quad over my liver, if there's a lot of extra fluid in there, it'll cause JVD. Left failure, lungs, right failure, rest of the body. Okay, now 9 out of 10 times, the right ventricle fails because the left ventricle failed first. But just like Megan said, afterload is resistance against both ventricles, okay? The afterload against the left ventricle has more to do with the aorta, and the afterload against the right ventricle has to do with your pulmonary vascular system. So if you have lung disease, somebody has pulmonary fibrosis, they have anything that causes the lungs to be stiff instead of spongy, you can actually get right ventricular failure without left-sided failure. My dad was one of them. He was in the Air Force and he was a mechanic and he worked around a lot of chemicals which caused him to have some lung issues. And so his left ventricle was as strong as it could be. We're going to talk about ejection fraction in a second. He had a normal ejection fraction, but his right side of his heart would fail every once in a while because it had to push against such an increased afterload in the lungs. Okay, so anyway, that's the difference between preload, stroke volume, cardiac output, and afterload or after resistance. Now, one thing we didn't talk about is ejection fraction. So let me do that right here. All right. So many of you guys have seen that your patient goes down for an echocardiogram, right? And you see what their ejection fraction is. And we all know that everybody should have an ejection fraction of greater than 50%. What they do, as simple as it is, they use an ultrasound and they look at how much volume is in the ventricle prior to contraction. So they look at the preload. So if there was like 100 mils in the ventricle prior to contraction, then they wait for the heart to contract and get rid of the stroke volume. If the heart got red and then they see how many mils are left. So let's say after the stroke volume has been stroked out, there's 40 mils left. That means 60 mils was ejected. Well, that's a 60% ejection fraction. That's good. Conversely, if my heart is failing and it's getting stiff and non-compliant, and I have 100 mils in there, and then they wait for the heart to contract, and then they look and they're like, oh God, there's 60 still left in there. That means I only have an ejection fraction of about 40%. Okay, it's more technical than that, but this is really just a generalized, simplistic illustration of what your ejection fraction, how they calculate it. Know that it should be, and I think on here it said greater than 55%. Anything less than 50%, and that person is probably in heart failure, or what we call cardiogenic shock. Okay, shock is not a low blood pressure. In our next thing, you guys are going to be watching a video of what I've already done. And I break down the different shocks. And shock simply means piss poor perfusion. And the one that's really got a high mortality rate, 80%, is cardiogenic shock. When the pump is damaged beyond repair, and by the way, once it infarcts, that tissue's never coming back. The rest of the heart has to make up for it. That's why we try to prevent myocardial infarctions. How are we doing on time?
We got an hour and 15 minutes.
All right. Just gotta take a sip.
We had a couple questions about, you know, the medications for preload and afterload. I would recommend that you guys go to, there's a specific page in your textbook under like the critical care, like hemodynamic monitoring, and that's on page 1538 for the 11th edition. You want to, it's the chapter, for those of you who have the 10th, it's the critical care chapter, and it explains in detail cardiac output, cardiac index, which is, you know, essentially cardiac output across.
That's what I wanted to talk about. You reminded me. Thank you.
And then also, if you, like, literally the book states which drugs decrease and increase afterload, preload, things like that. Like preload, if you want to decrease it, you give diuretics or vasodilators. If you want to increase it, you give IV fluids. And then
vasoconstrictors.
Pretty much anything that's, vasoconstrictors to increase preload. And then pretty much anything that's going to decrease your blood pressure decreases your afterload. So like your beta blockers, calcium channel blockers, ACE inhibitors, those are the ones. And then your book specifically states vasodilator drug therapy like milrinone can reduce afterload. So contractility is another one. You want to know your positive and negative inotropes. That's all in your textbook, so I won't spend too much time on that because Miss B already went over it. But if you feel like you're having a hard time understanding it, please reach out to me. I'll put my email address in the chat and we'll get you a session set up.
Yeah. I'm also doing some private tutoring too on Tuesdays and Wednesdays, so I'm more than happy to help you guys. Okay, so that's one thing I knew I was going to forget. So if I have a cardiac, we said that cardiac output, the amount of blood ejected each minute, is normally 4 to 8 liters. Okay, well, that's great. If I have a cardiac output, I'm 5'7", about $1.60. If my cardiac output's about 4 liters a minute, that's okay. If we have, let's say, Hulk Hogan or Warren Sapp, this big, massive person, right, with a big body surface area, and their cardiac output is 4 liters a minute, which is normal, but we decide that we're going to go running around the block here. Well, who's going to drop first? Hulk Hogan or whoever this big person is does have much more body surface area. So more specifically than cardiac output is called cardiac index, and that is also on page 5. If I take the cardiac output and I divide it by the person's body surface area, which you will not have to do, and if you ever work in ICU, the monitors do it for you, but you could go to on a page where it says your weight in kilograms and your height in centimeters, and it'll tell you what your body surface area is. Just know that your cardiac index, which is your cardiac output divided by your body surface area, should be greater than 2.5 liters a minute. I would know that. If the cardiac index is less than 2.5 liters a minute, you are in cardiogenic shock, which means you're going to go into heart failure. Okay? Let me define. I defined left versus right heart failure. I want to define systolic versus diastolic failure. Okay? Sometimes your heart is failing, but you're able to get an adequate stroke volume out. The problem is that the ventricle's stiff and non-compliant, okay? It's able to contract, but it can't stretch. It's a diastolic failure. If you have a patient who has an echocardiogram and their ejection fraction is greater than 50%, that is a diastolic failure. If their ejection fraction is less than 50%, that is a systolic failure. Got it? So compare and contrast. Left failure, everything you're going to get are symptoms in the lungs. Right heart failure, the rest of the body. Systolic failure, my ejection fraction is less than 50. and diastolic failure, I have a normal ejection fraction. I'm having trouble filling my heart. So that's when I'm going to get those extra sounds like S3, S4. Okay? All right, so let's see. Now we want to go on into, I'm going to share my screen again because I wanted to draw. What did I want to, oh, we're going to talk about MI. So go over into page 6. Well, let's continue down page 5. We're going to, in our next session, we're going to be talking about shock. So when the pump poops out, we have cardiogenic shock. That's a cardiac index less than 2.5. It could be caused by a myocardial infarction. It could be caused by infection of the myocardium or the pericardial sac. It could be drug toxicity, cardiomyopathy. But on page 6, here's what I would look at: clinical manifestations. Think about it. If I'm not getting adequate perfusion, my brain's not getting adequate perfusion, I'm going to have change in level of consciousness. I'm going to have elevated systemic and pulmonary preloads. So my CVP tells me my right ventricular preload, and my pulmonary artery wedge pressure tells me my left ventricular preload. So if my CVP is higher than 8, that's increased preload in the right ventricle. And if my pulmonary artery wedge pressure or diastolic pressure is greater than 12, that's increased preload in the left ventricle. Got that? CVP tells me right ventricle, pulmonary artery wedge pressure tells me left ventricle. So I'm going to have, this is the only shock where those two will be up. I'm going to have tachycardia, low blood pressure, and low cardiac output. Now, your pressure may go up for a while because of razzmatazz, the dance that my kidneys do, and giving me epi and norepi, but it won't last long. Elevated right preload, so my CVP will be up, elevated left preload, my pulmonary artery wedge pressure. If I wait for dusky skin color, you guys, this person's dead. We don't see cyanosis until somebody's PaO2 is 60 millimeters, is 60. And when I see a PaO2 of 60, only then do I see my sats dropping into the person became obtunded. It could mean that they became agitated. So let me quick share my screen with you, and I'm going to do a little commercial break here, and this should help you immensely. You want to make sure that when you see a change in level of consciousness, I want you to think of all these H's in a row. You rule these out in a row. The first might be hypoxia. Oh boy, hypoxia. Low oxygen. Then the next thing that brain needs a constant supply of is glucose. So maybe it's hypoglycemia. Or maybe I have hypotension, and that's why I'm not getting enough perfusion to my brain. And that could be due to hypovolemia. Or it could be that I have hyper or hyponatremia. The sodium, remember, wherever sodium goes, so does the water. Or it could be due to excess hydrogen ions. Maybe I have an acidotic situation. So that's just a little thing I love to give students to help you remember. If you have a change in a patient's level of consciousness, I want you to rule out, are they hypoxic? Are they hypoglycemic? Are they hypotensive? Are they hypovolemic? Then start looking, what about my electrolytes? Is my sodium too high because they're intravascularly dry, or my sodium's low because they're underwater and wet? Or do I have an acidotic situation? So I have too many hydrogen ions. Okay.
Real quick, I had a question from a student. I was getting the 10th edition of my med-surg book out of my car.
Okay.
She said, when ejection fraction is less than 50%, which failure did you say that was?
Left. They only look at your ejection fraction on the left side of your heart. Great question.
Thank you.
But what I would also say while we're talking about that is if you have a scenario where the CVP is higher than 8, I'm worried about too much preload in the right. And if my pulmonary artery wedge pressure is greater than 12, then I've got failure on the left. Okay, so do your compare and contrast, signs of left-sided failure versus right-sided failure, and what's the difference between systolic failure and diastolic failure. Okay, a lot of the time, the reason our heart is failing is because it has been damaged, okay? So let me show you, let me stop this one and go to screen, stop that share, and I'm gonna screen share. I've got another picture here if I can get it. All right, go to here. Oh, here we are. Okay, so here are those coronary arteries on the epicardium, okay? There's the left main and the left anterior descending. Here's the right coronary artery. So you can kind of see the left covers the left and down to the left side of the heart, the anterior portion of the left ventricle, and the right coronary feeds the right ventricle and comes under and does the inferior wall of the left ventricle. So we all know about atherosclerosis, right? It's that fatty stuff that builds up in our arteries, and you can see it here. And then what eventually happens, our arteries will distend as much as they can, then eventually they can't go anymore, and the artery is going to be narrowed. And foam cells develop, and then hardening, calcification, and eventually that calcified foam breaks off, and we have a piece that gets loose that becomes an embolus. And think about this, if this is where the embolus is, look, anything below it is going to prevent distal perfusion. So up here it's showing you if this artery gets blocked, then see where this is getting blue? All of this area is ischemic. And then you'll have an area of injury, and then you'll have a zone of infarction. And so our whole goal when somebody is having a myocardial infarction is to limit the size of the infarction, okay? So going down on page 6, just so you guys you can roll over it and read about atherosclerosis, left versus right hearts. I want you to go to page 7. We're going to talk about angina and an MI. So let me stop sharing for a second and I'll come back to that. Okay, so angina is a temporary ischemia of the heart, okay? And so usually this is somebody who has stable angina. They know when it's going to happen, right? And remember, you have the STEMI and the non-STEMI, and we'll talk about that. But angina is usually precipitated by what I like to call the E's, a clinical syndrome of pain or feeling of pressure in the anterior chest, often related to obstruction of major coronary arteries. It can lead to myocardial ischemia. Factors that can produce it, think of all the E's: eating, exercise, exposure to really hot or cold, or emotional stress. So I'll say it again: eating, exercise, exposure to cold or hot, and then emotional stress, because that kicks in the sympathetic nervous system. All right, the pain varies. A lot of times they'll get pain in the chest, in the neck, and the jaw. If it's stable, it usually will go away. If it's non-stable, then it might not go away, and it might not even be precipitated by one of the E's, okay? Pain is unpredictable, may happen with increased amount of stress, and it can also happen at rest. And it's not relieved by nitroglycerin, because we all know if somebody has chest pain and they've had angina, we tell them to stop doing what they're doing. They pop a nitro, they wait 5 minutes, they can pop another one, they can pop up to 3, right? Then they got to get to the hospital. One form of angina that is specific, that is not due to atherosclerosis, is called Prinzmetal angina, and it's more due to vasospasm. And a lot of people see this or get this kind of pain in the middle of the night, and it wakes them up. And when they do an arteriogram on these people, they do a coronary arteriogram, their arteries are wide open. What's happening is, much like Raynaud's disease, when you talked about peripheral arterial disease, it causes vasospasm. So if somebody's having Prinzmetal angina, they specifically treat those patients with calcium channel blockers. Okay, now let's go into somebody's having stable angina. We know what to tell them. Then they become having unstable angina. Now we need to know, do they have ST elevation or do they not? So I want to go back here really quickly and share the screen. Remember, I am not an artist, but I told you to really watch. Okay, here's my P, QRS, and T. Right here, okay, that's called the J point, where the S, well, it's right there, okay, right there. And you notice this is what we call the, geez, Diana, the isoelectric line that kind of runs through that whole thing. All those waveforms should be very close to that isoelectric line. All right, now I'm going to tell you a goofy story, but will really make sense. All right, if I am sitting here and I'm not getting enough oxygen, remember we go ischemia, injury, infarct. Within 20 minutes, we infarct tissue. So I'm sitting here and I'm realizing I'm not getting enough oxygen. I'm going to get very depressed because it's very depressing to be ischemic. So ST depression looks like this. PQR. See how deep that is? That is ischemia. Now, whenever somebody's having chest pain, we're going to do a 12-lead EKG. You can, if you see on telemetry that somebody has ST depression, ST elevation, you cannot assume that they're having ischemia or injury. You have to get a 12-lead and see it in 2 consecutive leads, okay? Now, real quickly, when you do a 12-lead, you'll notice that some of the waveforms, the majority of them are upright, but some are negatively deflected. It just happens to determine by where the leads are. So think about it. My SA node is up here in my right atrium, okay? In leads 2, 3, and AVF, the positive electrode is down there. So it's coming towards the positive electrode. That means in those leads, I'll have upright, okay? V1, V2, V3, V4, V5, V6. V1 and V2 are kind of over here where it's going away from it, so they'll kind of be lower, whereas V4, V5, V6, it's coming right at it. Those are going to be uprights. In lead 1 and AVL, where the positive electrode's up here, those waveforms are going to be negative. Don't flip out about that. We get a 12-lead EKG because it shows us, it looks at the electrical activity all over the myocardium. So if I know where the ischemia is happening, I know which coronary artery that is supplying, and I can tell where the problem is by looking at the 12-lead most of the time. All you guys need to know is what I'm telling you here. If I see ST depression, I'm ischemic, okay? Now, so here's my heart. And here's the coronary artery, and here is the area of ischemia. There's a big block right in my coronary artery, okay? And so that's decreasing perfusion. So here's the area of ischemia. Then after about, few minutes, I'm gonna start having injury, and then eventually, in less than 20 minutes, I will infarct. Now, the whole goal is to open that back up. I got to erase, where are we here? Eraser. Is to open this artery up and reperfuse all those areas and minimize the infarction, okay? That is the whole goal. So that's why we go through coronary, percutaneous, transluminal coronary arteriograms, and we'll talk about that in a minute. But we, as nurses, have to determine, is this person having an MI? Well, probably they're going to be having some chest pain. And then we're going to get a 12-lead EKG immediately, and we're going to talk about MONA. Don't let me forget about MONA. So if I've been sitting here for a while and you haven't done anything and I'm still ischemic, now I'm going to get pissed and I'm going to say, hey, I'm going to heighten my level of excitement. I'm going to say, hey, do something. I'm injured. I'm going to elevate the excitement, and I'm going to see PQR, woo, look how high off the isoelectric line that is. That is called ST elevation, MI, myocardial infarction suspected. We also call those tombstone T's, because if I don't reperfuse this coronary artery, this person's going to die, and we're going to have to get them a tombstone. Okay? Now, if after 20 minutes I'm elevating my excitement and you haven't done anything, then I'm just going to quit. And that is called a positive pathological Q wave. Q waves are normal. We see Q waves, but a pathological Q wave is at least a third the size of the R wave. So if you look at this Q wave up here, see, that's just a tiny little thing. Here's what I'm talking about. P, Q, R, and sometimes you'll even get an inversion of the T wave. This deep, big Q wave is called a pathological Q wave. And a pathological Q wave means that that area of the myocardium has infarcted, it is dead. It can no longer conduct electricity, it can no longer help in contraction, it be dead, okay? So that would be a myocardial infarction. So what are we gonna do? Well, I'm glad you asked. We are going to MONA them. We're going to MONA them. First thing we're going to do is put them on a monitor because we have to look for ST depression, ST elevation. We're going to put them on oxygen because it's got to balance the scale here. We want to increase oxygen supply and decrease oxygen demand, decrease that myocardial oxygen consumption. This person needs to be at rest. We don't want them to do anything. We don't, after somebody's had an MI, we let them, lay there for a while. We let them maybe feed themselves. We don't let them do a whole lot because we want that heart to rest. We give them nitroglycerin. Nitroglycerin, okay, helps dilate the coronary arteries. And it also is a vasodilator, which decreases afterload, which decreases that force my ventricle has to push against so I don't have to work as hard. And we give them aspirin. Remember, aspirin decreases platelet aggregation. It decreases the stickiness of the platelets that are part of that thrombus blocking the coronary artery. The difference between aspirin and, say, Ticlet and Plavix and all those antiplatelets is it sticks with the platelet the whole time it's alive, about a week to 10 days. That's why you have to stop your aspirin like a week before you have any kind of surgeries. The other part of M is morphine sulfate, okay?
Yeah,
We're going to give them
a couple questions about that, so perfect timing.
Okay. Good. The other thing is morphine. Uh-oh, somebody got unplugged. Somebody got mic'd. Okay. So the other thing is morphine, and morphine is going to block the sympathetic surge, which is good. Back off on my epi and my norepi. It's also a venodilator, and it also takes away the pain. If I take away the pain, I take away that circulation of epi and norepi, which would make my heart beat faster and stronger. So morphine's a great drug. It's a venodilator, so it helps decrease preload and stuff coming back to my heart, because when my heart infarcts, it's gonna go into failure, okay? Now, what do we wanna do? Well, we got to get this person. Now, if you look on page 7, myocardial infarction is cardiac cell destruction due to reduced, let me get off of here a second. Due to reduced blood supply, depleting the oxygen in the myocardium. Once the cardiac tissue has died, it is replaced with scar tissue. That's not good. Scar tissue is not going to stretch. It's going to be stiff. Changes in EKG reading and lab values will be seen within seconds after the onset of pain. Permanent damage does not occur until the cells have been denied oxygen for 20 minutes. So we want to get that person to a hospital that has a cath lab to get them in so we can maybe do something to open up this coronary artery. We also want to MONA them. We just talked about that. What you might see is pain radiating to the left shoulder and arm, but it can be in the face, jaw, and the middle of the back. Remember, women and diabetics have unusual, atypical kind of chest pain. The diabetics, because they're rusted from the inside from all that hyperglycemia, their nerves are not working well. And women, we birth 10-pound babies. We're like, it's just a little indigestion, not a big deal. They might have symptoms like fatigue. Their pulse might be rapid, irregular, especially if they have some dysrhythmias. And we're going to be talking about looking at EKGs, because a lot of the times a person's going to die from a cardiac dysrhythmia that resulted from a myocardial infarction. They may have pressure in their chest, they may have nausea, and they may have diaphoresis. Initially, the blood pressure will drop, but that once razzmatazz kicks in, it might go up for a while. Cardiac output is going to decrease. In the GI symptom, they might have vasovagal symptoms like nausea, vomiting, which can actually drop the heart rate. By the way, the right coronary artery feeds the SA node, and the left coronary artery feeds the AV node. So if the left coronary artery is involved, you're going to have higher levels of block. That's bad. If you have the right coronary involved, you might see more things like atrial fib, atrial flutter, first-degree AV block. Left coronary artery is obviously the worst because that's feeding the left ventricle. And when the ventricles are ischemic, they're going to start prematurely contracting. And we're going to talk about that. And then they might go into VTAC and VFib, and the person could die. Now, we talked about the catecholamines being released, epi and norepi, and glucose because of cortisol being released. Now, you need to know this, guys, your lab values. Lab results increase initially. It doesn't usually initially. It takes a little while for your white count to go up, your sed rate, temperature may go up, the blood glucose is going to go up, but most specifically are your cardiac enzymes. These are the enzymes that come out of your cardiac cells, the myocardial cells, as they apoptosis, as they actually destruct. They're going to dump out these enzymes. So troponin I and troponin T, I always tell students, think troponin T totally tells me if this is cardiac damage. Both increase within 4 to 6 hours, and they both peak in about 10 to 24 hours, but they stay up for 14 days. So if this person comes in 3 days after having an MI and their troponin I and T are elevated, it's very indicative that they may have already had an MI. Your CKMB, that's your myocardial band. CK is creatinine kinase, that's any muscle, but the CKMB is myocardial band specific. That goes up in 4 to 6 hours. I don't think I'd worry about how fast they go up, how long they stay. I would know what is the most specific one. Tell me I had an MI. And we would say troponin T. Okay, troponin I and T, but troponin T for specific. And then they might do an echocardiogram, and they can look at the wall motion to see if they have dyskinesia, dysfunctional wall movement, or akinesia, where it's not functioning at all. They're going to do an echocardiogram, which should be 55 to 60%. Look in your book. It says here, if less than 45%, that's indicative of systolic failure. I'm here to tell you, if it goes below 50 in the hospital, we're saying that's not good. But always look at the numbers in your book. That is your Bible. Now, something that can happen is from the inflammation of having an MI is that fluid can build up in that pericardial sac and cause cardiac tamponade. So we just want you to know that that can be a side effect from an MI. And what will happen is that the T waves will go off the Richter scale, just like in pericarditis. And your heart sounds will get further and further muffled away, and you will have a narrowing of the pulse pressure. Remember, I told you that pulse pressure is the difference between your systolic and diastolic. That narrowing pulse pressure is telling me my stroke volume is going down. If my stroke volume is going down, my cardiac output is going down, okay? And the other thing about cardiac tamponade, which I would remember that's specific to it, is called pulsus paradoxus. And that's where when the person inhales, their systolic blood pressure drops at least 15 millimeters of mercury. Okay, pulsus paradoxus. When they inhale, their systolic blood pressure drops 10 to 15 millimeters of mercury, and that is very specific to cardiac tamponade. I'm not going to go over pulmonary emboli, and I'm not going to. Cor pulmonale is the other term for true right-sided heart failure, and I think I went through that. 90% of the time, the right side of the heart fails because the left failed first. But in cor pulmonale, the CVP is above 8, but your pulmonary artery wedge pressure is not above 12. And it's simply somebody who has had underlying lung disease and their right ventricle is failing. These people oftentimes actually need more fluid into their pump because the right ventricle can't push blood over into the left side, which seems counterintuitive, but that is the case with right-sided heart failure. I wouldn't spend a whole lot of time on that. What we need to do is we need to go over EKGs. Meg, is there anything else? Are there any other questions about what we've gone over?
I haven't gotten any questions, so you guys feel free to drop it in the chat now. One thing I do want to mention is you definitely want to know, just like you had to know in level 2, the atypical signs that are usually found in like women, diabetics, and older adults of MI. So fatigue, nausea, shortness of breath. Those are some atypical signs that maybe when they walk in the ER, they may not recognize it as like an MI right away. But if it's a person who has, especially someone who has diabetes.
Megan, I'll be right back. Keep going.
Yeah, no problem. because they do have that neuropathy involving the nerve that provides sensory input from the heart, or it's more the reason it comes from the left arm. One of the PTA tutors was telling me is because it's the same nerve, the sensory nerve that innervates the heart and the well, not innervates, but pulls sensory input from the heart and the left arm. So that's why it's traditionally pain down the left arm, based on the way that the anatomy of that nerve is. But with diabetics, you have neuropathy, and so they may have something called the silent MI, where they would otherwise have chest pain, but they don't because the nerve itself is damaged from the diabetic pathophysiologic process. And these atypical signs also occur, especially in women. So that nausea, fatigue, anxiety is a big one, freaking out a little bit. So.
Okay, brilliant. Now I wanted to show them, and I thought I had a PTCA up here, but I'm not sure now. Let's see, that's the impella. Okay, so if this person is having an MI, we're going to get them to the heart cath lab as quick as we can. They're going to put a catheter in the groin, in the femoral artery. They're going to thread it up through the aorta and get into the coronary arteries, and they're going to inject dye. And let's say they see a narrowing right there. They're able to see that this is a narrowing and there is a plaque. They can bring the catheter down and they can do what we call balloon angioplasty, where on this catheter there's a balloon that will blow up and then retract and up and retract and push that plaque out of the way. And then they will actually put a stent there. I thought I grabbed a picture of one, but there's millions of pictures in your book. And they'll put, it looks kind of like a Chinese finger cot. And they'll put this stent and they'll leave this metal stent that's coated with an anticoagulant into the artery to keep perfusion going, okay? If they cannot do that, guys, and sometimes the plaque might be at a really funky juncture, like here at a bifurcation, then they have to do coronary artery bypass graft. So let's say, see where I'm pointing here? Let's say this is the problem, right? And I need to perfuse distal to that artery that is blocked. I will take either a saphenous vein in the leg or an aorta, see the big aorta full of blood, and I'm going to stitch one part of the graft there and bring the other part of the graft below where that blockage is, and that's called a coronary artery bypass graft. It obviously is open heart surgery, much more invasive than a PTCA, a percutaneous transluminal coronary intervention.
Hey, Miss B.
Yes.
We can only see the 5 photos from your computer.
No. Okay, that's not good.
I think you have to share screen again.
Hold on. How about that?
Yeah.
Okay. Yeah. So here's what I was saying. This is where they would bring the catheter in and use the balloon angioplasty to push that back up, and then they would leave a stent in there. Now, real quickly, you need to read the section about post-coronary artery intervention, because they've stuck a catheter up this person's femoral vein. That person's going to lay flat with some pressure on their femoral vein. You need to be checking distal perfusion in that leg. Just because they have a pedal pulse does not mean they have good perfusion to their toes. So their capillary refill. If all of a sudden you see a big bleeding at the groin site, where are you going to put pressure? Just above where you're seeing the bleeding, and you're going to keep pressure there, and you're going to call a rapid, because they might have to take them back. They might have done something to the artery, or there's an issue there. Okay, so you want to make sure you understand they're going to have to be anticoagulated post PTCA. Okay, we try to do that, because if not, then we're going to have to do the coronary artery bypass graft, which here's what you do. You take saphenous vein or one of the other veins or an artery in your arm, and you come up here to the aorta, and you stitch it there, and you bring it down, and you stitch it below where you have the blockage. When you hear somebody with a coronary artery cabbage times 3, times 4, times 5, that tells you how many detours they had to make around blocked arteries. So the more that they had to do, the higher the chances person's chances are of having complications. And you know what the complications are of that kind of surgery? Pneumonia, PEs, and all that kind of stuff. So make sure you do your review on how you're going to nursing care somebody who's had a CABG versus what you're going to do somebody who's had a post-percutaneous transluminal angioplasty, okay?
Miss B, do you mind if I add something real quick?
Go right.
So if very few hospitals are like this unless they're rural or very small, but if they don't have a cardiac cath lab, what they might use is thrombolytic therapy, similar to how they use it in a stroke. Now, if you're administering IV thrombolytic therapy, that would be without a cath lab. There is a way to administer it via cath lab where it's intra-arterial, so it requires less medication, is less dangerous to give. Because essentially this thrombolytic therapy is very different than anticoagulants or antiplatelets, but because it busts up existing clots. As you're administering it, you need to know what's normal for reperfusion and if someone reoccludes. So the way that I always remember that is that your reperfusion,
I'm glad you
might have those reperfusion dysrhythmias that resolve themselves, that they don't necessarily need medical intervention. And you would see alleviation of chest pain. Now, if they're reoccluding, whether it's during TPA, after it was successful, or whether it was after a cardiac cath, then it would just look identical to an MI. Like, think of it as they're just having a heart attack again. Like, they have chest pain again, they have STEMI, or they have an ST elevation. So you need to know kind of those signs as with the drug therapy like that.
I'm so glad you brought that up. We were going to talk about that next. Streptokinase, or TPA, tissue plasminogen activator, actually is a thrombolytic. It lyses and eats up the clot. Your anticoagulants prevent further clotting. They don't break up existing clots. So like she said, they'll normally take them into a cardiac cath lab, but if they're out in a rural ER, they can't get them into a cath lab. They may just give it, you in the ER, give that thrombolytic. Now think about this. Who are you not going to give a thrombolytic to? Hey, somebody who just had a recent brain bleed, or somebody who has a GI bleed. So know the contraindications for giving thrombolytics.
And there's a table, there are absolute and then relative contraindications. That's page 724. I think in both books, actually, because that's like the one page number I have blazed in my brain.
Nice.
Where it tells you like when you can't give TPA or when you can't give those clot busters to patients. And you need to know the absolute especially, because they just definitely can't get it. They have to have a clot in place to prevent hemorrhage. So that would be like someone who has active internal bleeding, known intracranial cancer, recent ischemic stroke within the past 3 months, severe uncontrolled hypertension. It's table 33.15 in the 11th. And then I'll type in the chat. Oh, wait, no, here it is. It's the same identical page, 724 in the 10th, table 33-13 though.
Brilliant, brilliant. All right, can you see this screen share, Meg? The intratic balloon pump?
Yep.
Okay.
Table
So
33 dash what?
I'm gonna retype it in the chat for everybody.
all right, so sometimes post-MI, the muscle is so weak, the person's in cardiogenic shock, and they can't push blood forward, and they go into heart failure. So one of the things that we can do to promote cardiac output is what we call counterpulsation, or an intra-aortic balloon pump. So what they do is they thread through the femoral artery this catheter, much like the PTCA catheter, right? They come up through here, it's bigger though, and it comes up through the aorta, and it's right outside the aorta, okay? Because remember, the left ventricle, here's the aortic valve, this is where the left ventricle ejects the stroke volume. So what happens is, it is timed to the EKG. During the QRS, which is systole, this 20 to 30 millimeter balloon of helium will deflate. And during diastole, this 20 or 30 millimeter balloon of helium will inflate. Well, you're like, well, how is that going to help? Well, I'm glad you asked. during diastole, when this balloon inflates, look what it's doing, guys. Now remember, this is oxygenated blood. It's pushing oxygenated blood back to the brain, so it increases cerebral perfusion. It's pushing it back right here to where the coronary arteries start, so it's going to increase coronary perfusion. And it's going, so we want it to do that, right? It's perfect. It's helping give good blood to the brain and good oxygenated blood to the coronary arteries. Now, when the ventricle starts to contract, look what it does. It rapidly deflates, causing a vacuum, helping unload that ventricle, helping get rid of that stroke volume. So it increases the stroke volume, it increases the cardiac output, and it decreases after load or after resistance. I could see a question about what does an intra-aortic balloon pump do? And if you just look at it and think about it, if during diastole that balloon fills up, that promotes coronary perfusion and cerebral perfusion. And then during systole, it rapidly decreases, causing a vacuum, helping increase my stroke volume, increase my cardiac output, and decrease my afterload. When that is not enough, then we have to go to what we call an LVAD, a left ventricular assist device. Can you see that, Meg?
Yep. This
Okay.
is, I always reference the Grey's Anatomy episode. If you guys were early Grey's Anatomy fans with Denny, Izzy cut his LVAD wire to get him higher on the cardiac transplant list.
I never watched it, but that's ingenious. Okay.
It was one of those like guilty pleasures of mine.
Oh my gosh. So here they actually take the blood from the left ventricle and they run it through a pump and put it right into the aorta. So it's just what it says. It's assisting the left ventricle. Now, when back in the day, I used to fly people with these and they were as big as a freaking dishwasher, right? And we had to have it right at a certain level. It was a whole big thing. Now they're tiny, tiny. Look, this guy's wearing the pack right around his belt. You know, you can do everything pretty much except they don't want you swimming. I think it was former Vice President Dick Cheney had his for like 2 years until he finally got a cardiac transplant because his pump was pooped. And now, I don't know if any of you guys have seen this. I'm just going to mention it because it is out there. The Impella, and the Impella, where are you? Is right here. This thing is weird. I have seen it. Can you guys see that? This actually goes into the left ventricle, and this little catheter, it works like a pump, and it goes around and around to help increase stroke volume and cardiac output. It's called an Impella. It's not near as invasive as a LVAD, but you can imagine if you got something inside your ventricle, it's going to be very irritating. These people have lots of cardiac dysrhythmias, and they have a lot of clotting issues. It breaks or bleeding issues because that thing flipping around in there is smacking against red blood cells 24/7.
Hey, Miss,
So
the photo didn't open all the way.
it didn't open?
No, I mean, I think you just have to go to share screen and then click the window that it opened into. It was like loading. You could see a little loading icon, but it's still just stuck on
Let's try that.
the cardiac pictures.
Is that better?
Yep, perfect.
Okay, so this is where it is, guys, in the ventricle. See, I also got one with your kidneys. See how important they are? They're telling you everything about your myocardium. But this thing is actually floated back through the aortic valve, through the right atrium into the left atrium into the left ventricle, and it's constantly wiggling around in there, helping increase stroke volume and cardiac output, but it does have lots of complications. Bleeding is a huge one. Okay.
I'm sorry to interrupt again. I do have a question from a student. How does the aortic balloon pump stay in place with all that blood flow? Does it have a pressure bag the way that an ABG line does?
Yes. Well, no. It's anchored in there. It's anchored in there. And you got that is a really good point because you have to make sure you're marking where it is inside the person's groin so that it hasn't come out.
Just like
And you would,
lines.
yeah. Yeah, no, intra balloon pump doesn't have a pressure bag. It stays in there because of the mechanics of the pneumatics.
Gotcha.
Okay, it's not like an A line where it's just sitting there monitoring a pressure.
Right.
That makes sense, I hope.
Yeah, thank you.
And obviously these people are in CVICU and okay. Now I'm going to try to screen share again and let's go with our EKGs. Do you see that, Meg?
Yep.
Okay, so guys, there is a handout called the 3 R's of Easy EKG. I am currently teaching a BSN level EKG course. And a lot of students from
I'll put it back in again. Sorry to interrupt.
No, what, honey?
I put it in the chat earlier, but I'll drop it again because I think some more people came in.
Okay, you're so kind, Meg.
There you go.
So what I always want you to do is I want you to think of the 3 R's. Now, if the heart is working correctly, we should have a sinus rhythm because that's supposed to be where the pulse is generated from, correct? So we're going to look at every rhythm and determine, is it sinus in origin? And if it's not, then what is it? Well, you only have to know so many dysrhythmias as an ADN grad, but I am seeing all of our SPC grads that are in my EKG course in the BSN got this because they listened. And if you do this with every rhythm you look at, you are going to be very proficient at reading EKGs. Remember, this is just the electrical activity generated by what's going on inside the heart. So, for quick review, every one of these little boxes is worth time, and every big box is worth time. So I'm going to come up here, and every little box, you can see there's 5 little boxes in every one big box. Okay, we'll start down here. Okay, 5 little boxes in one big box. Every little box is worth 0.04 seconds. So 0.04, 8, 12, 16.2. Every big box is worth 0.2 seconds. So if I count 5 big boxes, watch, 1, 2, 3, 4, 5, or up here where they already did it for us, 1, 2, 3, 4, 5, that's 0.2, 0.4, 0.6, 0.8, 1 second. So 5 big boxes is worth 1 second. So this is 1 second, 2 seconds, 3 seconds, 4 seconds, 5 seconds, 6 seconds. Got it? The first R I want you to think about is it regular? Now, I want not you just to think about the ventricles, I want to know, are the atria regular? So if I'm looking for atria, I'm looking at my P waves. If I take a piece of paper, okay, and lay it across here, and I put a dot here and a dot here between 2 P waves, then I can march that from here to here, and then I say, is that equal to here? And I can see very carefully that indeed it is, right? You guys can see me, correct?
Yep.
So what I'm talking about is taking a piece of paper Can you see me, Megan?
Sorry, what's that?
Can you see me?
We
Okay.
can see you.
I'm putting a dot by a P wave and another P wave, and I can march it down. That's what I'm talking about. I can take that same dot and put it on 2 R waves and go to the next R wave. And I can say, yes, my atria is regular and my ventricle is regular. That's good, okay? Because that's what should be happening if it's coming from the SA node. The next thing on my second R is rate. So I have to determine the rate. It's that if I was looking at a 6-second strip, and every rate is in minutes, right? How fast is my heart beating a minute? So how many times does 6 go into 60? 10 times. So if I am able to count the number of ventricular contractions in 6 seconds and multiply it by 10, I've got my heart rate, okay? So look, I'm not gonna count that one because it's outside of my 6 seconds. So 1, 2, 3, 4, 5, 6, 7, 8. Do we all get 8? So our heart rate is 80. Now I'm going to quickly go over this, and if you don't get it, I want to have some one-on-one time with you, or maybe Megan will have one-on-one time with you to make you understand this. Because every little box is worth 0.04 seconds, If I counted the number of little boxes, and then you take 60 and divide it by 0.04, you get 1,500. So I can count the number of little boxes between 2 R waves and divide it into 1,500, and it would give me my heart rate. By the way, that is the most accurate way of doing it. Or I can count the number of big boxes between 2 R waves, and since a big box is worth 0.20, 60 divided by 0.20 is 300. So for my heart rate, I could count the number of big boxes between 2 R waves, divided into 300, or count the number of little boxes between 2 R waves and divide it into 1,500. And that is the most accurate way of doing it. For your purposes, you have to have a regular rhythm. You guys are going to be responsible for atrial fibrillation, which is an irregular rhythm. You can't count the boxes on an irregular rhythm. You need to get a 6-second strip. So by counting the QRSs in 6 seconds, we said our heart rate was 80. Let's do some math here, guys. Find an R wave that's right on. You see where I'm looking at this R wave here, third from the right? Let's count the number of big boxes between 2 R waves. 1 big box, 2 big boxes, 3 big boxes, 4 big boxes. Well, what is 300 divided by 4? Isn't it 75? That's pretty close to what we got when we said that our heart rate was 1, 2, 3, 4, 5, 6, 7, 8. But it's a little more accurate. Now, if we want to be totally accurate, let's count the number of little boxes. There's 5 little boxes in every big box. 5, 10, 15. Notice that it's not quite 20. I think there are 19 little boxes there. So I take my handy dandy calculator, once I find it, and I say 1,500 divided by 19 gives me a heart rate of 78.9, about 79. So this is a normal rhythm. Okay, so if the little box, big box is more than you can comprehend right now, just count the number of QRSs in a 6-second strip, okay? If it's less than 60, it's too slow. If it's greater than 100, it's too fast. The last R is relationship. What do I mean? Well, every time the atria fires, the ventricle, that electrical impulse should go through the AV node and stimulate the ventricle. So we should see P, QRS, P, QRS. So is there a P before every QRS? Yes. And is there a QRS after every P? Yes. So there's a good relationship. I'm going to show you a picture later when there's more P's than QRSs, and that means there's an AV block. Now, the first R I said was regular. So what I want you to do is go back there and say, are my intervals regular? Is my PR less than 0.20? Well, I can tell that it is because here's the P and there's the R wave, and it's not bigger than 1 big box. And is my QRS less than 0.12? Yes. Less than 3? Yes, I can tell that. And how I could definitely tell it is take calipers or just take a piece of paper and put a little dot and then move it up to the top and read it. You guys aren't even going to have to be determining what bundle branch blocks are. The only block you all have to know is a 1st degree AV block, and we're going to talk about that in a second. So this indeed is regular. It's of normal rate. It has good relationship. My PR and my QRS are normal. Don't even worry about the QT right now. So I can indeed say with all sincerity and all thinking like, yeah, I've got this for sure, this is a sinus rhythm. But again, like Megan said, I always assess my patient, does he have a pulse? Because there is a form of a dysrhythmia called electrical pulseless activity or electrical mechanical dissociation. And that's where you see a rhythm, but there's no pulse. Okay, so we're going to go down to this next.
I actually had a question about that earlier, if you don't mind.
No, go right ahead, Eric.
Are you saying that electrically it shows like bradycardia, but mechanically it's asystole?
Exactly. And we treat it just like asystole. Yes. A lot of times if somebody's had trauma to the heart, if they have a pericardial tamponade, we'll see it, or severe electrolyte imbalances, we'll see it. The electrical activity is trying to get through the heart, but it's not really stimulating a mechanical contraction.
I think I've actually seen that once.
Oh, it's not fun.
I just didn't know what it was called. No,
it's
but
horrible.
we were seeing it, the electricity on the 5 lead and on the paddles. But when we did a pulse check in between the CPR, nobody could find anything, even in the femoral.
And Eric, you brought up a good point. A lot of times after you give the epinephrine, it will be enough to excite the electrical pathways. But if the heart's already been infarcted and it just can't contract, it usually means death.
Yeah.
There's usually not a whole lot you can do unless it was like a pericardial effusion and you can pull fluid off or something, or change your electrolytes really quick, but it's usually a lethal rhythm.
Yeah, no, they
Okay,
didn't
perfect.
make it.
Because you guys don't have to, it's not on your, that's not for them to know, is it, Meg? We're just telling you extra stuff. So
Let me check the module just in case.
I don't think it's in there.
I
Anyway,
don't remember it being, because I graduated in 2015 and I don't remember it being, but
well, in 1982, it wasn't there, I'll tell you.
I'll check and I'll tell you if it's on there. If I don't say anything, that means listen to what we said.
Okay, let's look at this next one. I got to see how much time I have so we can.
You got
Okay, we're
20
good.
minutes. And
We're
then
good.
Miss B, I actually I have an appointment after this, so I created a new Zoom session so that you said you could stay for maybe like another half an hour to talk to students. So I dropped that in the chat, the Zoom invitation, so that I'll have to end this so the recording doesn't get messed up. And then I've created you as an alternate host. So I'll send you that.
Will you email it to me? Because I
Yep.
don't have the chat. Okay.
Yep.
Brilliant, guys. Okay, so let's look at this. So again, if I could put, now notice, guys, the faster the heart rate, the closer the P's and the T's get together. I can put a dot between two P waves and march it out. I can put a dot over two R waves and march it out. This is a very regular rhythm. So the first R, is it regular? Yes, it's regular. Now let's look at the rate. Remember, from here, 1 second, 2 seconds, 3 seconds, 4 seconds, 5 seconds, 6 seconds. Meaning I'm not looking at this one and I'm not looking at that one because they're outside the 6 seconds. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. I have a heart rate of 140. The other way I can get the heart rate is, again, count the number between two R waves here. 1, 2, just a little more than 2. Well, 300 divided by 2 is 150. Or I can count the number of little boxes. 5 to there, and then another one. So I could say 1,500 divided by 11. It's greater than 150. It's a fast rhythm. Do we all see that? Now look at relationship. Is there a P for every QRS? And is there a QRS after every P? So we have good relationship. And again, I could look at my PR and I can see that the time it's taking for the SA node to fire and get to the AV node is not bigger than one big box. And my QRS is not greater than 3 boxes, so there's not a bundle branch block. So what I have here is coming from the sinus node, it's just fast, sinus tachycardia. Do I treat this rhythm? I don't treat any rhythm. I treat patients. So I'm gonna go in and see, did this person just get done exercising? You know, if it's a person that just got up and walked down the hall and back or whatever, and they had surgery and they're in pain, it might be because they're in pain. So I'm going to treat the pain. Or maybe they are volume depleted. So if I give them volume, right, their heart rate will come down because their stroke volume will go up. So I'm going to, like it says here, only treat the symptoms, right? So they may be dizzy, they might have dyspnea, hypotension. I'm going to treat the cause. You can try to get them to do a vagal maneuver. Remember, the sympathetic nervous system kicks the heart rate up. The parasympathetic brings it down. So if I can stimulate the parasympathetic nervous system, which is the main one, the vagus nerve, by doing Valsalva maneuvers, like going, holding my breath and bearing down like I'm trying to have a bowel movement, that will innervate my parasympathetic nervous system and override my sympathetic nervous system and slow me down. Okay.
I can tell you how many patients I've had do that, just trying to go to the bathroom and they just pass out on you.
Exactly. That's how Elvis died.
Seriously, it was like, I can't even count how many.
Yep. Funny story. I had level 1 students and we were at a rehab and it was our first day in clinical. So they're all walking behind me like little ducks. I'm Mother Duck. There's 12 of them, all in their cute little outfits. And all of a sudden I hear, help. I look in there, and this man is on the toilet, and he's passed out, this big guy, he's leaning against the wall, and the poor patient care tech is like, oh my gosh. So we go in, we help her get the guy, and we put him in bed, and I immediately take his feet and put him straight up, right? And he immediately comes back to consciousness and said, oh my goodness, what happened, right? And we got him, he was fine. And then we left the room, and my little students, they're like, oh, Miss B, you're so amazing. You brought him back to life. You just, oh, you're so, I'm not, listen, guys, it was no trick, man. I just lifted his legs because he had vasovagal, and I pushed all that venous return back to his heart and his brain, and he woke back up. It was no big deal. But for those first week little ones, they thought I was pretty smart. Okay, this next rhythm. Again, do the 3 R's. You can definitely see my P to P is regular, right? Remember, put 2 dots on a piece of paper, march it out. My R to R is very regular, so I can say, yes, it's regular. Now I want to know the rate. Okay, here's 1, 2, 3, 4, 5, 6 seconds. So that's 1, 2, 3, 4. Heart rate's about 40. Now let's do the other ways that I taught you guys. If I count the number of big boxes, here's one that goes right on the dark line. So if I count the number of big boxes between 2 R waves, because the big box is worth 0.20, I will divide it into 300. Watch. 1, 2, 3, 1, 2, 3, 4, 5, 6, 7.5. So 300 divided by 7 and point is 300 divided by 7.5 gives me 40. Okay, so same. Or I can be really specific and count the number of little boxes between 2 R waves. Okay, remember there's 5 little boxes in every big box. So there's 5, 10, 15, 20, 25, 30, 35, 36, 37, 38. And so I'm going to divide that into 1,500. 1,500 divided by 38 equals 39.4. So it is a slow rhythm. The last R is relationship. Is there a P for every QRS? Yes. Is there a QRS after every P? Yes. So the atria and the ventricle are talking. So we have a coming from the sinus node. I can also look, is the regular intervals? Yep, the PR is not too long. QRS is not too long. So I indeed have a sinus bradycardia. Okay, so again, we don't treat rhythms, we treat patients. So what is this patient gonna look like if they're not, if this is a 40-year-old, well-trained athlete, this is totally fine. But if this is an 80-year-old woman with congestive heart failure and her heart is only beating 40 beats a minute, she's not going to be doing so well, will she? She's going to be, she's going to be having symptoms. She's going to have fatigue, dizziness, might cause chest pain. And this could be due, you guys, due to hypothyroidism, or that we gave them too many beta blockers or calcium channel blockers, increased vagal tone like we just talked about. Maybe they were pushing on their neck and did a carotid massage, rubbing on their eyes. What you might see is they're pale, cool, hypotension, weakness, angina, dizziness, confusion, shortness of breath. Any of those things say this person is not tolerating this rhythm. I need to speed it up. Now, a lot of times it's due to much parasympathetic nervous system output. So if I can block that and let the sympathetic nervous system kick in, my heart rate will come up. So you better know that you give atropine. Atropine is a parasympatholytic drug. It lyses the effect of the parasympathetic nervous system, mainly the vagus nerve, so that my sympathetic nervous system can kick in and increase my heart rate. Okay? Atropine 1 milligram IV. If that doesn't work, I can also give them a transcutaneous pacer, where you put the pad over the sternum and the left apex, and you start slowly turning up the amplitude until you start seeing a pacer spike, and then you want to see a QRS behind it. That can only be done temporarily, and then if it's still a problem, they may have to have a permanent pacer put in. You do need to know first-degree heart block. So look at the rhythm right here, guys. Our 3 R's. Let's do rate first. 1, 2, 3, 4, 5, 6. Or count the number of big boxes between 2 R waves divided into 100. or count the number of small boxes and divide it into 1,500. So we have, let's just do a 6-second count. 1, 2, 3, 4, 5, 6. Normal heart rate.
Miss
It's
B,
regular.
say real quick. I just wanted to point out, do you guys see the tick marks at the very top? That's, if anybody wanted to know, that's why she's not counting the first R, because it doesn't fall within those 6 seconds.
Yes.
Each tick mark represents a second at the very top.
And thank you for bringing that up, Meg, because if on your test there isn't a tick mark, all you have to do is count 5 boxes and put a tick mark. 6, 8, 1. Okay, so, all right. So we know we have a normal rate, which regular. Let's look at the relationship. Is there a P before every QRS? Yes. Is there a QRS after every P? Yes. Now go back to regular. Are there regular intervals? Guys, look. If you put a mark right here before that P wave on a piece of paper and put a mark right there at the R wave, I can see it's almost 2 big boxes. It's at least 1.5. So it's greater than 0.20. But my QRS is still narrow. It's not greater than 0.12. So what do I have? I have a sinus rhythm that is taking a little longer than normal to travel from the SA node down to the AV. It is a sinus with a 1st-degree AV block. Not a big deal. This can happen just because of age. It could be because they had an MI. Some people who have had rheumatic fever will have this, electrolyte imbalances. Also think about your medications. Is this person DIG toxic? Have they got too many beta blockers, calcium channel blockers? Flecainide can cause it. Usually asymptomatic, and that's what you got to think about. I'm not going to treat any rhythm unless they're symptomatic. Okay, let's keep rolling here. Now, you have to be responsible for this rhythm too. Here we go. Let's look at the heart rate. Now you guys know all the 3 ways that I told you how to do it, so you can do it your own way. We're just going to do the 6-second count from here on out because of time.
Sorry to interrupt again. I have a question from a student. It's the space between the P and QRS that shows AV block.
Say that again.
Is it the space between the P and the QRS? It would be from where the P starts to where the Q starts.
Well, yes, it's really a PR interval, but the R is the first upright. So I'm going to measure. Can you guys see where I've got my thing? There's the P. And then I measure it right where it goes up off the isoelectric line at the R. Does that make sense? The Q and the R are right there together.
Yeah.
But it's a PR interval. So if this was negatively deflected, I'd take it from the P to where the Q went down. Okay?
Thank you.
Hope that answers it. All right. Here, let's do the heart rate. Again, 1 second, 2 seconds, 3 seconds, 4 seconds, 5 seconds, 6. So here's 1, 2, 3, 4, 5, 6, 7, 8. And by the way, it is definitely regular. Now, you're thinking like, well, there's too many P waves there, so don't even worry about them. But look, your R to R is very regular, okay? And if you put a here, and here, you would see that it is absolutely regular. Whatever those little waves are that are coming from the atria, they are also very regular. So it's regular, as a normal rate. Now look at relationship. You got to go, wait a minute, there's more than 1 P wave for every QRS, okay? These P waves do not look like normal P waves. What are they doing? The atria is going flutter, 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 and it's like a 3-to-1 conduction, okay? Atrial flutter, if you turn this strip upside down, it kind of looks like a sawtooth pattern. Now, I just want to compare it really quickly to atrial fibrillation. See, that is very different. The atria is not going, it's going, it's fibrillating. But in atrial flutter, it's kind of going, it's in a spasm, okay? Sometimes atrial flutter will degrade to atrial fibrillation. But the biggest thing with atrial flutter is how many of those flutter waves are getting through. Because the more that get through, the faster the ventricle will respond. So what do? First of all, it's one of the atrial tachycardias. They have that flutter waves. We call those flutter waves that look like a sawtooth pattern. The atrial rate can be up to 350. So we don't want the ventricle rate. We're glad that there's a block at the AV node. It can, what we just saw was a 3-to-1 conduction. It can get up as fast as 2-to-1. Here's all the different reasons people go into atrial flutter. Again, medications are a big reason. Coronary artery disease, hypertension, pulmonary embolism. What we got to worry about is when that ventricular rate gets above 100, and because the P wave, we no longer have that P wave contracting the atria, pushing more blood down into the ventricle. It's just kind of quivering. We're going to lose atrial contraction. We're going to lose atrial kick, which means we lose preload, which means we lose stroke volume, which means we lose cardiac output. So we may have to give a medication to slow this heart rate down, such as a calcium channel blocker or a beta blocker, or we can do what we call catheter ablation, where they actually go in a cath lab and they figure out where the irritable focus is in the atria that's going bloop, 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 and making the atria flutter, and they hit it with electricity or a really cold gas, and they knock out that little irritable foci, that irritable area of the heart, so that the node can kick back in, okay? The next one you need to know about is atrial fib. And the first thing that should jump off the page is that this is a very irregular rhythm. So it's not coming from the SA node. Let's check it out. We can't count small or big boxes because it's irregular. So here's my 6 seconds from there to there. Count the R waves. 1, 2, 3, 4, 5, 6, 7, 8, 9. It's about a heart rate of 90. I don't see any P waves. This is what, in flutter, at least it was doing this, right? In normal, we get the atria, the P wave, and then the QRS. Atria, QRS. Here, in flutter, the atria is going flutter, 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 then the ventricle goes flutter, 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 then the ventricle goes. Now, here's what the atria is doing. And then the ventricle is going, should I go now? Now? Do I go now? There's a very irregular R to R. And so we really lose atrial kick, okay? So it's irregular. I don't see any P waves. It's an okay heart rate. The ventricle's not greater than 100, but this is not a good rhythm. And the thing that we need to do, there's different algorithms that will follow depending on what's going on with the patient. But 2 reasons why that atrial fib is bad is you lose the atrial kick, so you lose stroke volume, cardiac output, and when the atria contracts and then the ventricle, the atria is pushing that blood out of the atria into the ventricle. As blood is moving, it doesn't get thick and clotty. But if the atria is doing, the blood's all getting thick and clotty in there. So what the biggest problem is, we're going to throw a clot either to the brain or to the lung or somewhere. So we have to anticoagulate these patients. And we have to give them rate control medications. Now, this person's heart rate is fine, but a lot of times with atrial fib, the ventricular rate will get very fast. And at that point, we have to give them medications. Sometimes they'll give DIG, sometimes they'll give a beta blocker, calcium channel blocker. They can use a sodium potassium channel blocker like amiodarone. Okay, I would be familiar with that medication. And if that is sometimes, when the person's stable, we start with the least invasive maneuvers and then we work our way to the more invasive. And the more invasive would be to cardiovert that person, okay? But what I mean by that is that we actually deliver an electrical shock. The heart responds to 3 things: electricity, electrical stimuli, mechanical stimuli, and chemical stimuli, okay? So if the electrical activity is out of whack, if I smack it with some electricity, I didn't mean to scare you guys, it'll go, it's like that. It's like smacking somebody who's hysterical till they can get their thought process back. And so we jolt the heart and then let the SA node kick back in. And that's called cardioversion. Now, if the person has a pulse and if they have an R wave, we call it synchronized cardioversion, because we're going to push the sync button and you'll see a little dot come over the R wave, because we want to deliver the electricity while the ventricle is contracting to try to get it to jumpstart. Okay, the big thing about atrial fibrillation, if we did have to cardiovert this person, it would be synchronized cardioversion because they have pulse. We would have to anticoagulate them first, or at least do a transesophageal echocardiogram to make sure they don't have any clots in there that if we jolted them, they'd go flying all over their body. So the medications I would be aware of, like calcium channel blockers, beta blockers, amiodarone, and DIG, I would definitely be looking at that, okay?
We have a question that says, do they need an anticoag for A-flutter?
No, that's a great question. Not necessarily. Not necessarily. Let's see what they put in here for you. Not necessarily, because what we try to do is get them back into sinus rhythm. And a lot of the times it will just resolve and go back in once we figure out what's causing it. Are they DIG toxic, blah, blah, blah. If for some reason, excuse me, the ventricular rate got too fast, then we might do that cardiac ablation. But atrial flutter doesn't cause as much clotting as atrial fibrillation. So no, they don't normally have to be on anticoagulants. Great question. Okay, now we are down to here. You do need to know this rhythm. Okay, it's kind of hard to see there because it's a picture. All right, and what I'm going to do, I can see that it's very regular, and I'm going to go to where I see right here. It's on a big line, and I'm going to count 1.5. There's 1.5 boxes between these two R waves. So 300 divided by 1.5 is very fast.
We also have a question. What about the utilization of a cardioversion for A-flutter? I think in your book, let me check real quick.
Yes, they can do it. They can do it. They'll do the ablation. If it's really, really fast, they're probably going to try a medication like amiodarone to slow it down. And if it was really fast and it was staying in flutter, they might cardiovert them, yes. And they would not have to, and I'm talking about somebody with a really fast heart rate where they're now hemodynamically compromised. They can, absolutely, you can, once that person gets more and more unstable, we got to think of more invasive things like, yes, electricity. It would be a synchronized cardioversion. And we would use lower levels of electricity as opposed to when we do unsynchronized cardioversion or defibrillation.
Hey, Miss B, my 3 o'clock canceled, so we can just keep going with this. So
yay! Oh, I'm so glad.
Right?
Okay. Okay, so this is fast rhythm. It's like 200. If you notice, it's regular, and the P and the T, you can't even see where there's a difference. They're coming together. Okay, so let's count this. It's like 200. That's way too fast. It is regular, but I don't see a P, and the P and the T are becoming one. So this is happening. Now, what do I want to do? I want to look at my QRS. See how narrow it is? That means whatever's in this fast parade is happening above the ventricle. Supraventricular tachycardia. I think it's probably coming from the atria because it looks like the P and the T are one, but I can't for sure say that. What I can for sure say is that it is a narrow QRS. It's very fast, 200. So this is indeed called a supraventricular tachycardia. By the way, atrial fib, atrial flutter, atrial tach are all in the blanket term of supraventricular tachycardia. Okay, so somewhere in the atria is a irritated foci that is beating 200 times a minute. So it's getting through the AV node and making the ventricles beat 200 times a minute. Now, it can be sustained, or it says right here, it can be paroxysmal. You may see a sinus and then all of a sudden like a 3-second run of a really fast paroxysmal atrial tachycardia or paroxysmal supraventricular tachycardia, and then it goes back to normal. All right. So what you need to know is that we're treating patients. If it gets really fast, it's going to lead to hemodynamic instability. Now, it could be caused, guys, from emotional stress, stimulants like nicotine, caffeine. Hello, let's talk about cocaine. I've seen lots of SVT in party people. Digitalis toxicity. If it gets above 180, we start seeing hemodynamic instability. We can start with what we call Valsalva maneuvers. That's where we have the person bear down. back in the day, I taught aerobics, and one of the other aerobics instructors was teaching a class, and somebody ran out. I was lifting at the time. I was just in the gym, and they go, "Get in here." Connie's like almost passed out. I ran in there and I felt her heart rate was like 180. And she told me that she had mitral prolapse. And so she was very prone to going into these tachycardic rhythms. She had a pulse. It was weak and thready. I laid her down and I had her do some Valsalva maneuvers. It wasn't kicking it. Then I pushed a little pressure over her carotid artery. By the way, you have to know if you're allowed to do that in your facility or not. Most of the times it's done by a physician. And it slowed down for a little bit, and then it kicked right back up. And I said, "Do you trust me?" And she looked at me like, "I think so." I had somebody go get ice water, a bucket of ice water. And I took her face. I said, "Take a deep breath." And I slammed her face in this water. And then she went, and her heart rate went back to normal. Have you ever jumped into water that was colder than you thought, and you're like, "I can't breathe"? Okay, you just vagaled yourself, baby, and your heart rate's probably 30. Other things are probably shriveled up too, but that's a different discussion. So those are all Valsalva or vagal stimulation. Sometimes that works. If not, we're going to hit them with a medication down like amiodarone or beta blockers, calcium channel blockers, or we may have to cardiovert. If they become very unstable, we're going to sedate them and synchronize cardiovert. Okay, it mentions Wolff-Parkinson-White syndrome. That's just an extra pathway that some people have up in their atria that makes them very prone to supraventricular tachycardia. Now look at me for a second. See how fast that is? But we have narrow QRS. I want you to see that as opposed to ventricular tachycardia. This is coming from the ventricle. Do you see how wide it is? Let me go back. See how narrow that QRS is? That's supra, above the ventricle. When I get down here, that is coming from the ventricles. It's wider than 3 big boxes, okay? We're gonna get there, but I just want you to compare and contrast. Okay, now this next rhythm, guys, go ahead, babe.
Sorry, about SVT is, you really wanna know which medications for that one, especially.
Oh, the adenosine.
Yeah,
I forgot to talk about it.
The adenosine is one of those drugs that you have to give really quickly because it has such a short half-life, and you literally have to flush it like within a millisecond of giving it. And it'll cause the patient to go into asystole for a brief period of time.
And so if they make it through, they're not going to like you because they're going to feel like they just died. It is not a fun medication. You give 6 milligrams, and you usually give it an antecubital, and you raise the arm because, like Meg said, it's got a really short half-life. And then if that doesn't work, we can give 12 milligrams, okay? Adenosine for SVT, supraventricular tachycardia. What does it do? It blocks the AV node, so none of those crazy fast things going on in the atria can get down to the ventricle, and it leads to a pause of asystole, and then hopefully it allows the SA node to kick back in.
And then
so
you can also give the beta blockers and calcium channel blockers as well.
Yes, you can. And but adenosine is one I forgot, so thank you, Meg, because that's huge, and you will get tested on it. Okay, now a lot of times when somebody's having an MI, as their ventricle has ischemia, injury, and infarct, it's going to get very, very irritable. Or sometimes a person might have hypokalemia or hyperkalemia, or they snorted cocaine, or they're hypoxic, or for a million different reasons, the ventricle will all of a sudden go, ugh, and it will just send out a premature contraction. So if you look here, see these 3 beats right here? They look really, really normal, and this one looks normal, and then a beat should come in here, and then all of a sudden you see this wide QRS, and the T wave is opposite of the R wave, and it is definitely greater than 3 little boxes. And you look at this one here, see, there's the S wave, and the T wave is opposite of that. There's the R, the S, and the T, and it came early. See, it's premature because the next beat should have come here. It's premature, it's definitely wide, and the T is opposite of the S or the R. These are called premature ventricular contractions, okay? What do you need to know about PVCs? Guys, look at how this one looks just like this one. You guys see that? The second and third beat look exactly alike. That means they're coming from the same irritated focus. They're unifocal, got it? But when I start seeing one that looks different, now I have multifocal. I have more than one irritated area in my ventricle, okay? So when am I gonna worry? If I have more than 5 PVCs in a minute, please write this down because you need to know it. Sometimes people just have PVCs, but if they start having more than 5 in a minute, if they are multifocal, they look different. They're coming from different foci. 5 in a minute, multifocal. Notice how these come every second beat. If they're coming every other beat, that's called bigeminy. So bigeminy, if the PVC is coming every other beat, or trigeminy, it's coming every third beat. Let me see, do we have some more?
High PVCs.
Yes, I'm going to treat it. But when am I, so my thing was, when will I treat PVCs?
Oh,
If I
okay.
see more than 5 in a minute, if I see multifocal, if I see bigeminy, trigeminy, or 2 or 3 in a row. And it's all written here for you guys, because
Yeah,
what
I was gonna
happens
say
is,
they are written up there under the description, the
Yeah.
different terms.
here's what can happen. Okay, look at what I'm doing here. Here's the P, the QRS, and here's the T. The first part of that T is what we call absolute refractory, meaning repolarization is taking place and nothing is going to mess with it. But when we get up here and the last part of this T wave, that's only relative. And that means that if a PVC, any extra heat hits right on that T wave, we call that an R on T phenomenon, and that can indeed lead to VTAC and or VFib. So in any of those scenarios, I'm going to treat this patient. I'm going to put them on oxygen. I'm going to put them on an anti-arrhythmic medication. And I believe the anti-arrhythmics you guys are responsible for, and Megan, you can correct me, amiodarone, lidocaine, procainamide, and magnesium sulfate.
You know what's ironic is that cocaine can cause PVCs, but the medications that help resolve them were derived from cocaine, like lidocaine and procainamide.
Isn't that crazy? It's pretty wild. It's pretty wild. So one of the reasons that we measure that QT, the measurement from the Q to the T that should be less than 0.40, is if that QT interval starts getting longer, people are at much more risk for having PVCs and VTAC. Okay, so we're going to treat the cause. If it's low oxygen, give them oxygen. We're going to, if their potassium's low or high, we're going to treat that, and we're going to put medication to. They are different parts of that sodium, potassium, calcium thing. All right, so no amiodarone, no lidocaine, no procainamide, and no magnesium sulfate. All right, so let's go to VTAC, guys. If I see this rhythm right there, I have to determine, first of all, does the patient have a pulse? Okay. If they don't have a pulse, it's kind of, Eric, like we were talking about, it's kind of a form of pulseless electrical activity. But if there's no pulse and you see this, first of all, look how regular that rhythm is, right? That R to R is very regular. If we count it in 6 seconds, it's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19. It's almost 200 beats a minute. Way too fast. And where's it coming from? I can't see any P waves. What I can see is a very wide QRS. So this is indeed ventricular tachycardia. Okay? That means my ventricle is going like this, tacking, which means there's going to be minimal stroke volume, minimum cardiac output. But if they have a pulse and they are stable, what do I mean stable? They're awake and alert and they can talk to you and their blood pressure's okay, then we will treat this with medication, okay? We will treat this with medication, And usually what we're going to do is give them the antiarrhythmic medications we just talked about, amiodarone, lidocaine, procainamide, or magnesium sulfate. Or if it doesn't abate and it doesn't go away, then we're going to have to think about using synchronized cardioversion. As well as if anybody becomes unstable, as soon as they become unstable, we think electricity, okay? If they're alert, we'll sedate them. If they're not, we're just gonna get it to them. If they have a pulse, we synchronize cardiovert, okay? And usually we use a lower amount of joules, maybe 50 to 100 joules, and we synchronize, meaning you'll see a little dot appear above every R wave, and when we push the buttons to deliver the electricity, it will hit right when the ventricle is depolarizing and hopefully reset it into a sinus rhythm. Okay? So we start out with medications and we go down into using electricity. If at any time they become unstable, we immediately get to the electricity. Now, so you looked at that. They had a pulse, we had to decide, are they stable versus unstable? If they don't have a pulse, we are going to treat it exactly like this rhythm. By the way, make sure that the person hasn't just pulled off a lead, okay? Go check, do they have a pulse? If you see this rhythm here, first of all, you're going like, it just looks like squiggly stuff on the EKG, all right? Now look at that rhythm real closely, guys. Do you see any QRSs? No. Look at the difference between that and atrial fib. In atrial fib up here, the atria is fibrillating, but you still have QRSs. Do you see what I'm saying? That's not ventricular fib, that's atrial fib. But down here, I have the ventricle. It's not regular. There's no rate. The ventricle is just quivering, guys. Guarantee you they're not going to have a pulse. So every pulseless individual, EPI, they're going to get epi. We're going to call a code. We're going to scream, I need help, and we're going to start CPR. Remember, the heart will respond to electrical, chemical, and mechanical. So we've got to get effective CPR. It's more important than getting air into their lungs at a rate of at least 100 a minute. You want to make sure when you're compressing that somebody's feeling for a femoral artery and they can feel that you got a pulse going. Then as soon as I can get that defibrillator into the room, I'm going to put the paddle on the sternum and the apex of the heart, or the hands-free pads. You can do it a sternum apex or front and back. And then I'm clear, you're clear, and I'm going to deliver the highest joules I can. Unsynchronized cardioversion. This person doesn't have a pulse. I have nothing to synchronize it to. So unsynchronized cardioversion is the same thing as defibrillation. Okay? And I'm clear, you're clear, douche. Give it the highest, whether it's monophasic or biphasic, it doesn't matter. Turn it up to the highest joules, like 360, and deliver it. And then hopefully, we're going to see a heart rate come back. If not, go back to CPR. By now, you got to get respiratory in there, thinking about intubating this person. Now we're going to drug, circulate, shock. Drug, circulate, shock. Like I said, every pulseless individual is going to get epinephrine, 1 milligram every 5 minutes. Circulate, shock. The next medication class I'm going to give are your antiarrhythmics. Maybe I'm going to give amiodarone, 300 milligrams. The second dose would be 150. Know your lidocaine, okay? It's 2 milligrams per kilogram. Know your procainamide. Know all your doses, guys, okay? So you're going to give that epinephrine, the catecholamine, circulate, shock. Then we're going to give an antiarrhythmic, circulate, and shock. And we're going to keep going, and we're going to try to figure out why they're not coming back. The longer somebody stays in VFib, the more likely they're going to go into asystole, okay? I hope to God that you can determine that that looks like asystole. That should be the easiest rhythm, but you have to confirm it in 2 different leads, okay? And you have to check and make sure they don't have a pulse, okay? If they don't have a pulse, every pulseless individual gets epinephrine, right? The reason we're going to give this person epinephrine, guys, is we're going to try to cause some electrical activity in the heart to get it to go into VFib so then I can shock it, all right? So with asystole, I'm going to do CPR, give them epinephrine 1 milligram every 5 minutes, and I can give them atropine 1 milligram every 5 minutes, up to a total of 2 milligrams. Again, the whole thing with this is to try to get them into a VFib so I can shock it. We have tried in the past, if we get any electrical activity, to try to pace them. And only one time in my entire career did I see a pacemaker work, and it didn't work for long, okay? Once a person gets to asystole, it's hard to get them back, unless they're cold, unless it was like a cold water drowning, or they're hypothermic. Then, you know, all your metabolism decreases so they can go longer without a cardiac output.
That makes sense because it's essentially what they do during a cabbage.
Exactly. We make them very cold and hypothermic so that they don't have, they're using less oxygen. Okay, now, if somebody's in a bradycardia and we have to put a pacemaker in, and by the way, we can, if somebody's in an SVT, a really fast tachycardia, we can actually turn on a pacer faster than where they are. Like if they're at 200, we can turn a pacer to 240 and capture the heart and slowly bring that heart rate down. It's called overdrive pacing. You may read about it. I don't think they're gonna test you on it.
It's in the
normal time. What, babe?
It is in the textbook now. I didn't think it used to be, but it is in the 11th edition.
So overdrive pacing means I'm overdriving that noxious, fast stimuli and then bringing it back down so that my SA node can kick back in. It's kind of along the lines of cardioversion. It's just a different way of doing it, okay? But, so now you're gonna get a couple questions about pacemakers. All we have here are ventricular pacers. That first rhythm there, what you see, guys, and a pacemaker, it can be a dual chamber where we put a lead in the atria and in the ventricle so that we can pace the atria and the ventricle and have it be more like a normal heart. These ones are just ventricular pacers, and where there's a wire that senses and also delivers an electrical impulse when necessary. So this pacer is at, let me see, 300, 150, 175. It's set at about 70 beats a minute. So what you're seeing is if the patient's heart rate drops below 70, the pacemaker, that little line right there, will start firing 70 times a minute. And then right after the pacer spike, you want to see a QRS. That means the pacer is working. It sensed that the heart rate dropped below the preset value, so the pacer fired and it captured the ventricle. You see a QRS. It electrically captured. Now I would have to go take the patient's pulse to make sure that it mechanically captured, okay? So they're gonna give you several rhythms and they're gonna say, what's going on? What's going on? And what I want you to say is, what is the pacer doing or not doing? So look at this next rhythm. Looks to me like they're in underlying atrial fib, and there's a little pause, and it's hard to see, but there's a pacer spike and a QRS, and a pacer spike and a QRS, and a pacer spike and a QRS. It's working well. Once the heart rate dropped, the pacer spike happened, and I got a QRS, and a pacer spike happened, and I got a QRS, and then look, it slowed down again, pacer spike, QRS. All of these are the patient's own beats. So this pacer is indeed working fine. Don't be confused. If it's working fine, then there's no problem with the pacer, okay? Don't be what's the word, fooled. Now, look what's happening here. I have a pacer.
Burgess,
Yes.
does it matter that it's inverted the wrong way?
No, honey, that's a great question.
Yeah,
it does not matter.
Chat as well.
Okay, it does not matter. And the reason it's doing that, C, is because this is probably a lead 2, okay? And so in the normal heartbeat here, where the atria was fibrillating and it goes down through the ventricles, I have normal upright QRSs. But here, when there was a pause, the pacer in the ventricle sent out an electrical impulse, and then the ventricle responded. But because the electrical activity happened in the ventricle, we have a wide and negative deflected QRS. That's a great question.
My other question is as far as this pacer spikes are concerned, like on as far as the second strip which you're on now, which your cursor is on, I can't really see an actual spike versus the one
Victoria,
that's on top.
I guarantee you that in your one that you have for your test, you'll be able to see it. But what I want you to know, sweetheart, is if you looked right there, you can see it, and you can see it right there, and it's coming exactly 70 beats a minute. And they're going to ask you a question about the pacer, okay? So you're going to go, oh, okay, there must be a pacer spike there, and a QRS, and a pacer spike, and a QRS.
I think a big thing too that helps is noticing the pattern, because even though, you know, they kind of look like PVCs a little bit because they're like wider.
Right.
But you can see kind of that there's this bold line right before it. If you notice the pattern, like this is a demand pacer, which the one above it is a normal pacer where they're pacing every beat. Whereas for this one, you can see the heart rates. You've got the regular QRSs, and like Miss B.
Well, like this is also because I think we lost me.
What's that?
I lost you for a few minutes.
Oh, okay. I was just saying, like Miss B said, this patient looks like they're in AFib at the bottom, and the ventricular rate is really quick, and then all of a sudden there's a pause a little bit, and like it's a little slower, and then all of a sudden it's like, oh, this is taking way too long to fire, and so the pacemaker spikes because it detects that the heart is not beating, and it'll be set at a certain rate. So that's the difference between the demand. But if you can notice the pattern, then that's a huge.
Megan, you're cutting out.
Okay, I'll let you explain. I don't know why I'm cutting out. My Wi-Fi sucks today.
That's okay, baby. That's okay. All right. So most of the time, pacers are demand, meaning that they're going to only kick in when the person's intrinsic rate drops below. But sometimes it's just going to be a set rate. Now, here's this one, guys. So you can notice that you look at, Victoria, you can definitely see these pacer spikes. Big old pacer spike. Come on. And then QRS. Pacer spike, QRS. Pacer spike, QRS. Now watch. Pacer spike, no QRS. Pacer spike, no QRS. Pacer spike, no QRS. Finally, I get another pacer spike with a QRS. So think about it. What is the pacer not doing? It's sensing. It is firing. What it's not doing is capturing my ventricle. So this is called failure to capture. Got it? So when you look at these paced rhythms, determine what is the pacer doing or not doing. It definitely is firing and pacing and sensing here. It's sensing that it needs to fire, and it is, but it's not capturing. How do I know that? Because there's no QRS after the pacer spike. And then the only other thing that you might get is, look here. These are a little harder to see, but this initial thing is a pacer spike and then spike. So the pacer sensed, it fired, and I got a QRS, and then it fired and I got a QRS, and then it fired and got a QRS, and it fired and a QRS. Now look, my own ventricle contracted here, and the pacer failed to sense that, and it fired. And that's not a good thing. Look over here. The pacer fired right while my ventricle was contracting. So in this situation, the pacer failed to sense my intrinsic rate. And that can be deadly, because if the pacer fires on that relative refractory period of the T wave, it can lead to VTAC and VFib.
Same idea as like the R on T phenomenon, right?
It is. And so I would just look at the pacer strips and compare and contrast. You're only going to have 3 options. It's working, okay? It's sensing and it's capturing, or like this one, it sensed and it fired, but it failed to capture, or it's failing to sense the person's underlying intrinsic heart rate, and it's actually firing. Oh, all right.
Miss B, I know you just got the chance to take a break from lecturing, but I did get a question earlier that I wanted to wait till the end.
Yeah.
The student was asking which rhythms do you cardiovert and which ones do you defib?
That's a great question.
Those are all listed on the worksheet, but I'll let you kind of explain it.
It's always going to be a fast rhythm, correct, where the patient is symptomatic and unstable. Okay. I'm going to synchronize cardiovert only when there's a pulse. Okay, only when there's a pulse. So that could be a supraventricular tachycardia, and it could be a ventricular tachycardia if they have a pulse. When am I going to defibrillate, which is the same as unsynchronized cardiovert? It's when they don't have a pulse. So pulseless VTach and ventricular fibrillation. And the only difference is synchronized, I hit the synchronized button and I use less electricity. And unsynchronized, I crank up the electricity and the sync button is no longer on. This has happened in the past. I might be taking somebody who has VTach, they become unstable, they have a pulse, and I synchronize cardiovert them and they frickin' go into VTach. That's happened numerous times. So what do? I turn off the sync button, crank up the defibrillator, and hit him again, unsynchronized. Then I go to my drug, circulate, shock.
And then the only one without a pulse that we don't defib is asystole. You have to get a rhythm before you can shock it.
And that's a great point. And that's why I stress that we give that person epinephrine to try to get them into a VFib so I can defibrillate them, hopefully back into a sinus rhythm.
So hopefully that answered your question.
If not, ask away. So I'm here, Meg's here. What kind of questions do we have?
We got, what's the difference between pacemaker and implantable cardioverter
defibrillator? Oh, that's great. Well,
set to a minimum heart rate. Also, we had Eric was saying he performed CPR once and the patient's internal defibrillator shocked him.
Yeah, that sucked.
Yeah, that hurts a little bit, doesn't it?
It was, you know that sensation you get when you stick your tongue to a 9-volt battery?
No, I've never done that. I don't know.
Really? That's how you test whether or not the battery's still good. It's just like,
I did that to my son one time. I wouldn't do it to myself. Here, stick your tongue out.
It was like 60 of those all at once. I was doing CPR and it just went 3, 4, right up my right arm.
I've been tased before.
Yes. Okay, so an AICD, an automated implanted cardiac defibrillator, okay? And now the newer models, they have pacers and AICDs all together. It's groovy. It's really groovy. But an AICD is going to determine, these are people who have already had MIs, they have CHF, they're prone to going into VTach, VFib. It will sense when the person doesn't have a pulse, when their heart quivers, and it will give them an immediate electrical jolt, a very small amount, and right to the heart, inside, because the lead is inside the heart, so they don't have to use as much electricity. That's what an AICD is. Whereas a pacemaker is going to have a wire, several wires, one that senses the intrinsic heart rate and the other one that delivers a little jolt 70 times a minute. They have the demand ventricular pacers, they have AV pacers. The AV pacer gives you 2 spikes. You'll get a spike in the atria and a P wave, and then a spike in the ventricle and a QRS. That's really good because now I have preserved atrial contraction, atrial kick, okay? They also have, believe it or not, most of these are demand pacers where you just set, if it goes below 70, it'll kick in. There's ones called activitrax, so that if you're an athlete, it will sense when your muscles need more, and it'll actually crank up the pacer to go at like 120 a minute because you need that extra cardiac output. More than what you need to know right now, but I just want you to understand that that's what's out there.
I also had a comment from a student that said that an internal defibrillator shouldn't shock someone while they're doing CPR, so don't be afraid to give CPR if they have an ICD.
AICD. Yeah, the newer ones really should not. There was probably something a little haywire with that. But just like, we're teaching people how to use AEDs, automated external defibrillators, and it's pretty idiot proof. Put pads on patient, step away, analyzing rhythm, no rhythm detected, shock patient. It's that, because we realize the quicker the less time there is between no pulse and electricity, the greater the chance that this person is going to come back to life. The longer, the greater the chance of them not going to come back to life.
The trick with that IED is, ICD, is that oftentimes if you look at the code cart, you'll see a circular magnet about yay big on the side of it. That's what turns it off. You literally put it on the person.
I'm so glad that you said that, actually, because I want you guys to go, for 10th edition, on page 774 to 776, you need to know patient and caregiver teaching related to someone who just had a pacemaker placed. You need to know table 35-13 for the 10th edition.
I'd like
want to
to
move
say
their arm around.
something.
Can you say the page again?
Yeah, it's I'm gonna type it in the chat too. Page 774. Well, actually, you could probably go back 773 to 776. You really need to know table 35-13 on page 776, like the teaching and the post-op considerations for a pacemaker being placed.
And Megan, did you know where the table was as far as post PTCA nursing? There was a table about that, about care after somebody's had
the one where it's like, make sure you don't do any like range of motion with them afterward because the wires will get dislodged.
Right.
Yeah, that's in that whole text. And then that's that table is the pacemaker one.
And I'd like to make a comment about that magnet. You don't put a magnet over the device if the device is actually doing its job. You're only supposed to put the magnet over the device if the patient works in an electrical field and you don't want the device to go off, then you put the magnet over the device. But if a patient is being shocked, you can give them CPR. It's not going to harm the person that is performing the CPR. It shouldn't shock them, especially the ones that have them nowadays.
Yes.
And if
back in the day, there were some that would shock you because
It was a much older model.
Yeah, I have one. If I'm getting shocked, I would prefer that someone is going to do CPR on me. I don't want someone to have the fear of not touching me because they're afraid of getting shocked.
And
I would prefer that they come and do CPR.
Agreed.
He also kind of said it wasn't like too bad. It was like the 9-volt battery. So don't be scared.
No.
I don't want people to take it the wrong way and think, oh gosh, I can't touch him. She's being shocked or he's being shocked. Just know that that's not normal. You can still touch them and do CPR on them.
Right.
Absolutely.
The AICD is doing its job for sure.
And also that was a much older, a geriatric patient who's had it for quite some time.
Yeah.
One other thing that you don't come across very often, but when you have a patient that passes and they have that, you tape the magnet to their chest because oftentimes it'll keep firing even after they expire because it's still trying to start the heart again. So
Yeah.
Don't think you guys are going to have any test questions on that, thankfully.
I have a question from a student: radio frequency catheter ablation versus cardioversion, and what were the 5 drugs Ms. B mentioned? Amiodarone, adenosine, lidocaine. I think you mentioned magnesium.
Yeah, okay, let's go back for a second. Let me think about the drugs first since you asked that. The antiarrhythmics you must know are amiodarone, lidocaine, procainamide, and magnesium sulfate.
And then the adenosine is for the SVT.
Right. The first 4 are ventricular antiarrhythmics, and then adenosine and amiodarone can be for SVT. Now, she asked me, what was the first part of the question, Megan?
What's the difference basically between radiofrequency catheter ablation and cardioversion?
Brilliant. Okay, so radiofrequency catheter ablation is usually for an SVT. Okay, this is in a patient that keeps having runs of SVT, and they'll take them into what we call the cath lab and do potential studies, and they can actually determine, they can map out on the epicardium where this irritable foci is, okay? Then they'll slip the catheter in there, and either they'll use electricity or they'll use a gas, and they can do cryo or they can do the thermal probe, and they'll zap that area of the heart and kill it, that electrical path there, so that hopefully the SA node will kick back in and go down the normal pathway. That is very specific, okay? And that's an internal thing. Whereas synchronized cardioversion is just like a generalized slap to the heart, okay? It's not very specific. It is specific in the fact that we synchronize it with the R wave during depolarization, but it's hitting the whole heart, where catheter ablation is just one area of the heart, and we're trying to eliminate that irritable foci from making the heart go so fast.
There's also an explanation of it in the packet from the book as well, under, I think it's under the AFib or AFlutter.
Cool.
Any other questions, guys, before we wrap it up?
Was this helpful?
Yes.
All right, cool.
Yay, we got lots of people.
I mean, I'm looking at a lot of dog faces and cute little things, and I can see some of your good looking faces. So it's so good to see smiles and thumbs up. And I didn't see anybody fall asleep. That's always a good thing.
We got a lot of thank yous. And then, oh, okay. Someone asked if they can send.
I lost you again, Meg. What was the last thing you said?
Am I doing okay now?
Yes.
Okay. About their care plans, if they can send them into NIP. We don't review care plans via email and send it back to you. What we do is we do a Zoom session with you and work on the care plan with you. The way that I approach care plans is I ask you to give me a report, like as if you were giving me a report on a patient on the floor, because I need to know everything about your patient. I think a lot of you guys have simulations now because, you know, you're not in clinicals as much. But you do have to make an appointment one-on-one to go over care plan. So go ahead and fill out the student tutoring request form under the NIP Student Commons under course content, need a tutor, and then there's like an explanation of like how to fill it out and send it back. And we can
Are we still doing functional dimension care plans, guys?
Yeah.
Okay. Well, then I just sent this and Megan uploaded it into the NIP Commons, and it's about a 20-minute video that I did, because I've taught all levels, on breaking down how to do that functional dimension care plan. Yeah. So you might not have 20 extra minutes to spare, but if you need to, go back there and check that out. Are we still doing them on SimChart?
They're doing SimChart. You're not doing SimChart?
No, thank God.
We're not using SimChart anymore?
No.
SimChart go bye-bye.
Are you serious?
It's not that we're not using SimChart. It's that since not everyone can actually get to the clinical sites, they're using SimChart as the patient. So the professors are creating a patient for us in SimChart. We get our information from there, do the 10 boxes, and submit that along with there's a cardiac questions and stuff like that that we have to answer in a separate file.
You still have to do pathophys and the meds and the labs and all that stuff? Okay.
Yes.
Some do, some don't. Okay. Well, anyway, if that's helpful, it's there.
Everybody says thank you, and everybody loves you and us and NIP. So thank you guys for your gratitude.
Yeah.
So I guess we'll wrap it up, and I'll have this posted by the end of the day. Usually YouTube takes a minute to, by minute, I mean 5 hours to process videos. So.
Let me see, their test is next Tuesday?
Yep.
Is that correct? Okay, so I have some hours tomorrow, Tuesday and Wednesday. I think tomorrow I'm tutoring from 2 to 5 and Wednesday from 10 to 1 or something. And I don't think all of the slots have been filled. So as you are studying, if you need a little bit more one-on-one, or there's 10 of you that want to come together, you just have to fill out the form through NIP, because there's only one beautiful Megan, who, by the way, is my protege, who I am so proud of. She's brilliant. She was one of my students. And so it's so cool to see her succeeding so well and helping you guys so much.
Oh,
where will the link be to find the video?
It'll be, I'm going to post, usually what I do is I post an announcement to the NIP student commons, which you all are in. And then that'll go to your My Courses email. And then it'll, like, the announcement's going to explain where I put it. It's gonna, for sake of simplicity, it's going to be under course content. And then if you scroll down, you know how the little side panel has like things you click on? It's under level 4. It'll probably be toward the bottom.
Okay.
And if you don't want to listen to this one again, you can go back into the ADN Commons and go down to NIP and look at level 4. And my videos from, I don't know, 6-7 years ago are in there. So.
Also, every video that I post for level 4, I include on YouTube. There's this little eye in the corner. If you click on that, that takes you to the level 4 playlist. So like for the final, if you want to go, it's easy to go back and listen to like the one we did on acute intracranial problems.
Nice.
And they're either at the beginning or the end of the video.
Very cool.
Cool.
Pretty sweet. All right, guys.
Thank you.
Somebody said this has been incredibly helpful. This is the best lecture we ever had. I greatly appreciate your time and passion for education. Y'all are the best. All caps, thank you.
That's awesome. That's why we do it.
Yep. I'll see you guys around. Thanks, Miss B.
Megan, you're gonna stay on?
Thank you.
I don't know if everybody's gonna sign off. I'll give you a call.
Okay.
Okay.
Bye, everybody.
Bye.
God bless. Do well.